A very warm and hearty welcome to all the dignitaries present here today. As we continue our learning process, I would like to welcome you all on the second academic day of the 8th annual conference of the RSSDI BIHAR chapter. As the sun goes up, let the light of the knowledge be followed by it. With these words and without further ado, I would like to call upon the first moderator of the day, Dr. Rajesh Kumar sir, for a panel discussion on the topic diabetic foot. Over to you, sir.
A very good morning to all of you. First of all, I'd like to extend my thanks to our chairman, scientific committee, Dr. Sehwag Guha sir, and organizing secretary, Dr. Vijay Kumar, for giving us this opportunity. There's a famous saying that when you encounter a diabetic patient, you should don't look at his face, look at his feet. That's right, I'm talking about diabetic foot. As we all know, diabetic foot is a severe major complication of diabetes. The gravity of the situation can be understood by the data that 0.3% of the population of diabetes, or 1 in 300 person, undergoes amputation because of this diabetic foot. So for this we have a panel of discussion. In this we have 5 doctors. So one by one I would like to invite them to the dais. First is Dr. Milind Jha. He'll be talking on working anatomy, and then followed by Dr. Ashraf Azam. He'll be talking on pathogenesis, and Dr. Dilip Kumar from ARA. He'll be talking on types of diabetic foot. Dr. A.K. Aditya from Samastipur. He'll be talking on management, and Dr. Bharat Kumar from Darbhanga. He'll be talking on prevention of the diabetic foot. So, Dr. Milind Jha, please. Can we start, sir?
So with the permission of the chair, and without much ado, I'd like to start the session with the unfeeling, unbending, and unhealing foot, that is the diabetic foot, and we'll discuss about how anatomy is related to the action we should have in clinical terms. So as you have, as Dr. Rajesh has already set the tone, we know that there are 1.2 seconds that is being taken all over the world for a new ulceration. So a new ulceration is happening in diabetics every 1.2 seconds. Every 20 seconds, there is one person who is getting amputated. And there is a 15% life risk of diabetic patients who will develop diabetic foot ulceration during their stay. And as you see in the left inset, it is an NEGM study done in 2017 which says that just developing a diabetic foot ulcer or just healing it is not enough. There is a tremendous relapse rate of ulcers. At about 3 years, it's somewhere around 62%. So, anatomically, I'll try to make it as crisp and juicy as possible because simple anatomy tends to be a little drier for us. So I have tried to arrange the anatomic topic into 3 important aspects because of which the diabetic foot ulceration happens. The first aspect and the most important aspect is the architecture of collapse. It is motor neuropathy which is causing structural failure preceding ulceration. So there is the first motor unit failure happens, which is involvement of the distal nerves, because of which there is atrophy of the lumbricals and interossei of the feet. After that, these intrinsic muscle mechanics fail, as a result of which this atrophy destroys the guy wire mechanism. It's kind of the mechanism which holds the architecture of the foot. The extensor digitorum longus gains unchecked advantage, causing development of claw feet. And the third, there is fatal migration. So deformity forces the plantar fat pad to migrate distally into the toe sulcus. And as a result of which, the metatarsal heads are left naked. So there is no support beneath them, there is no cushioning effect. which creates high pressure points to the tune of more than 50 newtons per centimeter square, and that is what is the classical development of a neuropathic ulcer. The second concept that I want to allude to is that of the angiosome. So there are multiple arteries. The main three arteries that supply the foot are the posterior tibial, anterior tibial, and peroneal arteries. But these arteries divide into arterioles and they have their own areas of supply, and each area is known as an angiosome. So this is a vascular angiosome concept that I want to allude you to. And as you can see in the picture, there are a total of 8 arteries which are where there are 3 angiosomes from the posterior tibial artery, 1 angiosome from the anterior tibial artery, and 2 angiosomes from the peroneal arteries. Now these angiosomes communicate between each others via collateral vessels which are known as choked vessels. In diabetes, the main problem is that these choked vessels get blocked because of atherosclerosis, because of medial arteriosclerosis, etc., etc. But as a result of which, there is ischemia causing, development of further worsening of foot ulcer. So the main takeaway from this point is that whenever we are, dealing with a choked vessel, we would like to do a direct revascularization. Or if there is a, say, choked vessel near the medial plantar artery, which is a branch of the posterior tibial, we would not go ahead and catheterize the posterior tibial. You would like to revascularize the particular medial plantar artery, because the choked vessels, they will not let the blood flow from the posterior vessel to the medial plantar because they are already choked. So the takeaway point is direct revascularization of the specific artery supplying the ulcer's angiosome yields significantly higher rates, up to 86 to 86.2% of limb salvage versus indirect revascularization. So that is the second concept I wanted to allude to. The third thing that I want everybody to look at is the neuroischemic axis failure. So this is where anatomy kind of meets the physiology. So there is sympathetictomy. Because of diabetes, we already know there is autonomic failure. So there is loss of sympathetic tone causing the opening of arteriovenous shunts. Second, the hemodynamic paradox. So blood bypasses the nutritive capillary bed, so flowing directly from arteriole to venule, and the foot feels warm and pink due to the shunting, but actually it is effectively ischemic and the tissue is suffering because of the shunting. So that is the second thing which happens at the neuroischemic level. And the third thing that happens is functional ischemia. So even with patent macrovessels, healing potential is compromised by microvascular dysfunction. So capillary leakage and thickened basement membranes are the pathophysiologic mechanisms behind it. So what is the takeaway from this concept? That diagnostic thresholds, like relying upon the ankle brachial index that causes pseudohypertension because of these mechanisms, is not right. So basically we should be testing for toe pressures. So less than 30 millimeters of mercury is severe impairment, and carbon dioxide partial pressure in the toe less than 30 millimeters, again marker of poor healing. And Doppler for accurate prognostication. We cannot use ankle brachial index for prognosticating diabetic foot. So diabetic foot is basically a triad of tragedies. So as you can see, the neuropathy causes the unfeeling foot, the peripheral artery disease causes the unhealing foot, and the biomechanical failure is causing the unbending foot, which is basically described as Charcot foot or rocker bottom foot or equinus deformity, etc. So the diabetic foot represents the convergence of the unfeeling, unbending, and unhealing foot, creating a perfect anatomical storm for ulceration and amputation. There's one more thing that is anatomically important for patients dealing with diabetic foot ulcers, because the infection is always tracking away from the ulcer into the deeper spaces. So these are the hidden highways of infection. So there is a silent spread in diabetic foot infections which follows the path of least resistance, and the central plantar space is the most critical for that. The second thing, anatomically important, is the master knot of Henry. So it is basically kind of a choke point caused by the crossing over of the flexor hallucis longus and the flexor digitorum longus muscles. Now in diabetes, because of the motor unit failure, this choke point fails, as a result of which the infections track into deeper spaces, proximally into the deep posterior compartment of the leg without obvious superficial fluctuation. And the third thing, if you encounter a swollen red digit, it is often the tip of the iceberg only. So this is for a surgical emergency. Suspect deep compartment abscesses if systemic signs like fever or raised DSR appear absent due to immune paralysis. So that is where just looking at a swollen red digit should not end the matter there. You should be really careful that we probably are looking at just the tip of the iceberg. So anatomy is not really academic, it is actionable. If we have the right knowledge, we will be able to screen for the right things, assess correctly and prescribe in the right manner. So the three anatomical mandates that I want everybody to go on with is prevention through understanding. Point number one, peripheral artery disease is often asymptomatic in diabetic patients due to concurrent neuropathy. Emphasizing the importance of objective vascular assessment in all patients regardless of symptoms. The second thing which I would emphasize here is that we tend to just palpate the dorsalis pedis and comment upon whether the peripheral vascular supply is maintained or not. But in 12% of the patients, normally dorsalis pedis is absent. Second, the diabetic foot ulcer is rarely spontaneous. It is the predictable end point of an anatomic failure. So our role should be to know the anatomy, identify the failure point and intervene precisely. And thirdly, by mastering the functional anatomy, we shift from reactive wound care to proactive limb salvage, transforming clinical outcomes through anatomical precision. Thank you so much for your kind listening. Thank you.
Thank you, Dr. Milind. Your speech was really very enlightening for us. Now I'd like to invite our second panelist, Dr. Ashraf Azam, who will be talking on pathogenesis of the disease.
Good morning to all of you. Before going into the details of the pathogenesis of diabetic foot ulcer, I would like to recall the famous quote of the great legend, genius, Leonardo da Vinci, who talks about the human foot as a masterpiece of engineering and a work of art. So, first we have to describe what are the foot at risk foot. Foot at risk are those foot which are susceptible to ulceration and loss of tissue viability due to neuropathy, vasculopathy and immunopathy. The signs are, when you see the foot of the patients, there are red marks, bluish discoloration, which are maybe the early sign of gangrene, and indrawing of toes, indrawing of nails, overriding of toes. That is also known as cramping of toes. When you see these things, you have to be alert, because intervention at this stage can further progress the ulceration formation. So the pathogenesis is multifactorial and complex. It is heavily influenced by persistent hyperglycemia, which leads to endothelial dysfunction, chronic inflammation, oxidative stress, and immunological dysfunction, leading to delayed wound healing of the lower extremity. So, diabetic foot ulcers are the results of complex interplay of various factors like metabolic, vasculopathic, neuropathic, and mechanical, all leading to ulcer formation. We will discuss it one by one. First of all, we should know about neuropathy. In neuropathy, diabetic neuropathy, around 50% of diabetic patients have neuropathy. And these are sensory, motor, and autonomic dysfunctions, all of which contributes to ulceration conditions. In sensory neuropathy, there is loss of pain, temperature, vibration, and loss of joint sense, in which patients does not notice about the unnoticed minor trauma, injuries, and various things. Suppose a patient, there is a stone in your shoe. In diabetic patient, who has neuropathy, they cannot apprehend it, leading to microabrasion and ulceration formation. In motor neuropathy, there is weakness, there is degeneration of neurons, leading to muscle wasting, atrophy, and the architectural change in the foot, such as claw toes, hammer toes, and charcot joints. All this leads to uneven pressure distribution on the plantar surface of the foot, causing deep pressure and leading to ulcerations. There are certain deformities which predispose to ulceration, such as claw toe, hammer toe, charcot joints, and other things. The callus may be a nidus for infection, and it would ultimately lead to ulcerations. In autonomic neuropathy, there is anhidrosis, decreased innervation of sympathetic glands, leading to decreased sweat solution. The skin becomes dry and cracked, and it provides a nidus for infection and ultimately leading to ulceration. So to understand the to understand the neuropathy, we have to understand the basic pathogenic pathway, that is diabetic neuropathy pathway. Among these, it is sorbitol pathway, that is polyol pathway, that is very important. What happens in non-diabetic person, only 3% of glucose is shunted to the sorbitol pathway. But in uncontrolled diabetes mellitus, approximately greater than 30% of blood sugar is shunted to the sorbitol pathway. Here, glucose is changed into sorbitol by enzyme aldose reductase, and further sorbitol is changed into fructose by sorbitol dehydrogenase. And the coenzyme NADPH, which is very important coenzyme for scavenging free radicals, are depleted. So this pathway is very important because this pathway is seen mainly in non-insulin dependent cells such as lens cells of the eye, neurons, and the nephrons. Here we are concerned with neurons. You know that when sorbitol comes, sorbitol draws water inside the cell. It leads to increase in osmotic pressure. What happens, that cell bursts and it leads to cell death. So sorbitol and fructose, conversion of sorbitol to fructose is very slow. So, and this fructose is also cause formation of advanced glycosylation in products. These are also very harmful, causing generation of reactive oxygen species, cytokines that perpetuates inflammations and maintains the pro-inflammatory states. Next is vasculopathy. We all know that there are macrovascular complication of diabetes and microvascular. In macrovascular complication of diabetes mellitus, diabetic foot is only one of the several things that happens. The major macroangiopathic complications are stroke, MI, angina pectoris, peripheral arterial disease such as mesenteric ischemia, gangrenous ulceration leading to diabetic ulcers, and in macroangiopathy there is actually the major cause is atherosclerosis. What happens in atherosclerosis? There is a plaque formation. As a result, there is a decreased blood flow to the tissue, and when the blood flow is reduced, the the cells, the immune cells like neutrophil, monocytes, which are supposed to go to the site of action, does not go, and there is, as a result, there is delayed wound healing. And in macroangiopathy, there is formation of advanced glycosylation end products, and there is thickening of capillary basement membrane, and these advanced AGEs are deposited subintimally, and this causes generation of free radicals, and there is a decreased immune cell infiltrations and poor wound healing, and ultimately it folks to gangrene. Now the final, last but not the least, immune dysregulation. This is the area where there is a tremendous interest in this immune dysregulation. No matter how much blood sugar you control, it is absolutely vital to control blood sugar, but only to control blood sugar you cannot get the desired result. You have to act on each and individual pathway, such as you have to block the neuropathic pathway, the immunologic, and the vascular. It's a complex sort of things. So the recent interest has been on immune dysregulations. What happens when chronic hyperglycemia triggers the generation of inflammatory cytokines like interleukin-1 beta, T1 necrosis factor alpha, and interleukin-6. It all activates the NF-kappa beta pathway, which leads to formation of free oxygen radicals that contributes to chronicity of the wound and the delayed healings. And the macrophage polarization is very important. The generation of AGS, advanced glycosylation end products, leads to polarization towards the M1 phase. Normally what happens, in inflammations, there is conversion from pro-inflammatory M1 to anti-inflammatory as the inflammation progresses to healing stage. In diabetic patients, what happens that there is the persistence of the pro-inflammatory M1 phase. These phenotypes cause generation of free radicals, free oxygen radicals, lots of cytokines, and the environment of the wound is inflammatory wound, and it causes persistent inflammation and leading to poor wound healing. And anyone can ask that if at what stage this inflammation is arrested in diabetic foot ulcer patients, then it's the proliferative phase in which inflammation is arrested. So the focus is on not a single pathway. We have to deal with all the pathogenic mechanism, all the pathway, so that we can effectively treat the diabetic foot ulcers. Next speaker will talk on the management, but one thing I have noticed that the drugs such as empagliflozin and canagliflozin has got not only reduces the blood sugar, but it also has an immunomodulatory effect, and it has been found useful in diabetic foot ulcer patients. Thank you.
Thank you, Dr. Srinivasan. You were very loud and clear in your thoughts. Now I'd like to invite our third panelist, Dr. Dilip Kumar. He'll be talking on types of diabetic foot. Over to you.
Diabetic foot is a disease complex that can develop in skin, muscles, and bones of the foot as a result of nerve damage, poor circulation, and infections. According to WHO in 1995, it is defined as a syndrome in which neuropathy, angiopathy, and infections lead to tissue breakdown, resulting in morbidity and possible infections. Classification on the basis of etiology, which I already discussed by my previous speaker. Now classification and staging on the basis of depth of ulcer. The first classification, traditional Meggitt's and Wegener's classification, which is based on Depth of the severity of ulcer penetration, which is most widely used, it ranges from the grade 0, indicating the intact skin with the high risk, to grade 5, which denotes the extensive gangrene of the foot. The next classification is Institute of Texas classification, which is based on 4x4 matrix classification. It has 4 grades and 4 stages. The stage is A to D, which denotes the present or infection, and with grade stages and grade A. It is considered as more descriptive and better predictor of amputation and healing time due to inclusion of infection and ischemia stages. The next classification is third. Third one is the Amy, Edmond and Foster. The third is Amy, Edmond and A.V. Foster classification based on the natural history and clinical condition of the ulcer, ranging from the stage with intact skin to the stages leading to the major amputation. In conclusion, understanding the classification of diabetic foot helps in risk stratification, guides the treatment decision, and play a vital role in preventing the amputation. Thank you.
Thank you, Dr. The workable classification, diabetic foot is very right, is Wegener's classification. That's very simple. It's range from 0 to 5. Where the 0 is there is no ulcer. In 1 there is the superficial ulceration is there. And in stage 3 we have deep ulcers. And in stage 4 we have, along with the ulcers, we have osteomyelitis. And the 4th and 5th is gangrene and the complete gangrene. One is the half thickness gangrene and the full thickness gangrene is there. That's a very workable diagnosis, as already said. This is now I'd like to invite Dr. A.K. Aditya for management of the diabetic foot.
Good morning to you all. First of all, Treasurer RSSDI is here. I would like to congratulate Manish Kumar here. And next, such a fantastic management and meticulous effort by the RSSDI this time in Bihar. And a special thanks goes to the chairman, the coming chairman now, and the secretary with the treasurer and all the patrons. I came all the way. What I have witnessed till now is really stupendous. And in life, without management, everything depends on your managerial skill and the management. From the juiciest start to the CDP finish, from Dr. Millen, from the clinical anatomy, the functional anatomy, beautifully elaborated. From Dr. Ajam, pathogenesis, to Dr. Dilip, a very good classification you mentioned. But the thing which depends on me, I will try to simplify it in just 4 minutes time. That is diabetic foot management. First of all, for management, we set a goal. Here also, in diabetic foot management side, we set goals. And what are the 3 goals? Number 1, prevent amputation and preserve limb function. Why it is being caused? Mentioned earlier beautifully. So, the first would be offloading. What do we mean by offloading? Offloading means on and off, both type of pressures in the wound, in the ulcers. How will you offload it? By listening your pressure. How will you listen your pressure? Wearing proper foot wear. Second, if there is excessive pressure point in the plantar area, then the one thing is total contact cast, TCC used. Here I will caution you one thing. We claim to a specialist. No. We have to work like a specialist. We have to prove our expertise, because if there is certain error, this will be a great failure. So total contact cast is a matter of total expertise. Then other thing, use wheelchair according to the ulcer, the type of pressure on the ulcer. Next is vascular optimization. What do you do in vascular optimization? You have been told about neuropathy, you have been told about the vasculopathy. It means if the area is choking, you can do two things. Send the patient one to the vascular surgeon. What will he do? Revascularization. How will he do revascularization? Which area to be revascularized? How will he decide? First of all, go for imaging techniques. And then after imaging techniques, you fix it by doing either catheterization or the surgical means. The next is infection control. If infection is there, the physician diabetologist like us, how will you decide what you have to do, what not to do? Next slide, you will see what is in our area, where I have to refer the patient to the vascular surgeon. So next is wound care. How will you care your wound? Next goal would be promote ulcer healing. All the four things which I have mentioned till now, that also applies there. Then is prevent recurrence. How will you prevent recurrence? I have mentioned use proper footwear, diabetic footwear, proper education. We are diabetologists, we are physicians. Always take care, spare few minutes time and counsel the patient properly. Without counseling, our motto is not fulfilled. Aware the patient, make the patient aware. I will again repeat, the one mnemonics which I have personally felt, I am disclosing to you, is diet. D-I-E-T. D means diet. E means exercise. And then the treatment last. Where we stand? First, counseling part में हम देखेंगे कि our motto is to aware, make the patient aware of his conditions, and we have to explain about the diet and exercise, and we always have to make them aware these are your medicines first, then the treatment last. So education has got the strong position here. Then surveillance. Next slide I am mentioning. I will simply go fast through the slide. Surveillance. What do you mean by surveillance? Surveillance means either from the health workers, they will annually go to the health worker, they will fully examine your foot and counsel you about that. And second is self-inspection on a daily basis. Next is risk factor modifications. This is through the proper education. We aware the patient, we train the patient how these are the risks, and you will by your practice modify your risk factors. This is a beautiful slide. Managing patient with diabetic foot. See the algorithm. Patient presents with diabetic foot ulcer. First of all, we have to search, is there any infection present or not? If infection is not present, then does the patient have adequate circulation? Two things we will simply search. Number one, dorsalis pedis and posterior tibia. That will decide, yes, circulation is not proper, then our duty is to refer the patient to the vascular surgeon. This is now our jurisdiction is not here to decide. Only to decide where the adequate circulation is there or not. And next, if yes, circulation is there, refer the patient to one of the following high-risk foot clinics. आज के दिन में podiatrics भी अच्छे आ रहे हैं. So, high-risk foot clinics, vascular surgeons, podiatrists specializing in diabetic foot ulcer. Then, for us, outpatient management we can do, that is wound care, offloading and surveillance. I have earlier told about the meaning of surveillance. And next is, if infection is present, then we have to define the infection in two categories, mild and moderate infection. Either this will be a cellulitis, mild infection, if cellulitis criteria is less than 2 centimeters, smaller in size, then we start with outpatient management with antibiotics and proper dressing. If it exceeds for foot care, again we refer to the one of the following. Then what about the moderate infection? Mild may only cellulitis will be there. Moderate, you will find cellulitis with purulence. Lesion size more than 2 centimeters. And if the infection is of severe type, then you will find sepsis there. What will you do now? Take the patient in IPD, hospital admission, and then start with all these things. That is ADR. What is ADR? Antibiotics, debridement, and revascularization. And I have mentioned all these things in the previous slides. So I will not want to waste my time here. And next, I will finally come on to this summary of the management of diabetic foot. See, pathogenesis, Dr. Ajay has mentioned. Treatment modalities, just see multidisciplinary care. What do you find here? Must have a good glycemic control. Offloading devices. There are many offloading devices. Go and learn it. Then debridement. Why debridement? And we have to do debridement in such a way that granulation tissue should come as soon as possible, it should develop. Then the healing will start rapidly. Advanced dressing. Two things we do. NPWT and other is hyperbaric oxygen therapy. And for future purpose, this is in present. We should also see the future, what are in store. We should go for stem cell therapy, macrophage modulation therapy, and personalized medicine. Personalized medicine, these days, you will learn a word, we bio-individualize the treatment. So, this is the personalized way. Phenotypically, thoroughly you examine the patient, thoroughly you counsel the patient, and then you decide tailor the particular type of treatment for the particular patient. Thank you. Thank you.
Thank you, sir. Your presentation was really fantastic. Everything was very nice, and your voice modulation, slides, and the way you had expressed it was really very nice. Now I'd like to invite our fifth panelist, Dr. Bharat Kumar. He will be talking on prevention of diabetic foot.
Good morning, all of you. So everything is discussed in the previous slides. Now the last thing, but the most important thing is the diabetic foot prevention. So first of all, to prevent the diabetic foot, we must have to first control the glycemic control, and there are some prevention method we will have to adopt. So prevention and the long-term monitoring. The first thing among that is the patient education. The ongoing education on the proper self-care, daily inspection, and the appropriate footwear is the vital. The regular screening, that is the annual comprehensive foot examination for all individuals with diabetes, with more frequent that every 1 to 3 month follow-ups, and high-risk patient with a history of ulcer, amputation, and loss of peripheral sensation and peripheral artery disease. The therapeutic footwear, that is the prescription of the specialized footwear for the high-risk individual. In this, the RSSDI role is also there, that is initiative like the 3-minute foot examination promoted by RSSDI, aim for the simple, effective screening in the busy clinical setting. Now the daily care that should be routinely followed, the inspect daily, check the entire foot for cuts, blister, redness or swelling, use of mirror for the bottom of the foot, the proper hygiene, that is wash the foot daily with the lukewarm water, test the temperature with your elbow fist, so that if there will be the peripheral sensation loss, then we cannot feel the peripheral sensation with the finger. Dry it thoroughly, gently paying the special attention to the area between the toes, and moisturize it wisely. Apply the lotion to the top and bottom to prevent the cracking, but never between the toe to avoid the fungal infection. Now the protective measure is the footwear. Wear well-fitting shoes with broad toe box. Avoid the high heel or tight shoes that cause the friction. Nail care, that is the trim the toenail step across the heel scrap edges. Seek the professional help for corn or calluses. In the safety is the first, that is the never walk barefooted, even the indoors. Always check the inside shoes for pebbles or objects before the wearing. Healthy habit and risk management. The first thing is the glycemic control. So first of all, we must control the glycemic level by the drugs and the healthy lifestyle management, and keep the blood sugar level within the target range is the crucial to prevent any type of risk, that is the neuropathy or vasculopathy. And if the person is taking smoking, we must advise him to stop the smoking, because it restricts the blood flow and significantly slowing down the wound healing. And the patient must be educated about the regular low impact exercise and improve the circulation of the overall foot health. Now if they will seek the professional care, then among that the annual examination, a comprehensive foot examination by a podiatrist is essential at least once a year to assess the nerve function and circulation. When to see a doctor, seek the immediate medical attention if you notice non-healing sores, significant redness, swelling or changes in the skin temperature. Early intervention is required for treating the minor issues. Early prevents the severe complications like ulcer or amputation. Thank you.
Thank you, Dr. Bharat Kumar. We'll follow the golden rule: prevention is better than cure. So we are finished with our discussion. Now I'd like to compile it. That is, basically we have today learned that there are two things in diabetic foot. There is sensory neuropathy and peripheral arterial disease. Sensory neuropathy leading to nociception, where the patient is not aware of the injury, and so the repeated trauma leads to ulcer. Further, the ulcer becomes infected, and once it gets infected, the healing is not proper because of peripheral vascular disease. The blood flow is less because of different pathogenesis, like there is a basement membrane effect, basement membrane is affected, and there is atherosclerosis, all these leading to poor blood flow, and so the healing of the ulcer is affected, further leading to gangrene and leads to amputation finally, if it is not properly taken care of. So by this, any questions from the audience we would like to take up? Yes.
Hello, good morning. First, I would like to congratulate all the panelists who has beautifully designed each and every aspect of diabetic foot, whether it is pathophysiology, whether it is anatomy, whether it is a treatment. And I would like to congratulate Dr. Rajesh too for beautifully moderating this session. So my question is with my grand senior, Dr. Adit sir, who is really my grand senior, was been given a beautifully treated about the diabetic foot. Sir, I just want to know, mild to moderate is great, but do you think nowadays the laser therapy is being advocated? Is it implicated in diabetic foot ulcer? Whether not mild, whether not moderate, severely we can't do, we have to amputate. Number one. Number two, you have given the hyperbaric oxygen treatment. Nowadays, I think it is absoluted because oxygen can promote the infection itself. So what is your take regarding this laser therapy in diabetic foot, especially in moderate stage?
Very good question. But answer is rather difficult. The modest place like Bihar, laser is an emerging thing. It's the highly skilled thing. Mild to moderate, we can certainly do it, but at the higher center. Here we are not practicing. Few vascular surgeons may practice it, or might be practicing, I am not knowing. But theoretically, I am knowing that this has the application. Second is hyperbaric. This is also a thing. Today it is, you are right, it's an obsolete thing. We are not using. But at the higher center, if it is refractory type of ulcer, we are using antibiotic, we are debriding it, everything doing. Is still healing difficult and not even proceeding to the serious side. Then we try to go for the hyperbaric treatment. If we get the result out, okay. If not, leave it. Thank you.
Thank you, sir.
Any questions further? So I declare this session closed. Thank you.
Thank you to all the panel members for a light of knowledge on the topic which remains unexplored. Your guidance and expert opinion would certainly keep our fellow doctors in the treatment protocols. Now, I would like to call upon the panel members for the presentation. Dr. Manish, sir.
Feel bit lucky to facilitate our expectation at Dr. Panache sir and Dilip sir. Please.
Dr. Bharat Kumar sir, you have your Thank you to all the members. For the second panel on another interesting topic of gestational diabetes mellitus, I would like to call upon our moderator, Dr. Anjani Kumar sir.
A warm good morning to everyone. So, I am thankful to the organizers who gave me an opportunity to moderate this panel discussion, and it's my pleasure to invite you all to participate in this panel discussion on gestational diabetes, which is a condition which is very common in a significant number of pregnancies worldwide and has important implications on maternal and fetal health. To proceed with the panel discussion. To proceed with the panel discussion, I would like to invite our panelists. First, I would like to invite Dr. Shyama. He is an associate professor in the Department of General Medicine at AIIMS Patna. Secondly, I would like to invite Dr. Janmeshwar Prasad. He is an assistant professor in the Department of General Medicine at AIIMS Patna. Dr. Jyoti Dinkar is associate professor, Department of General Medicine at IGMS Patna. I would like to invite Dr. Narendra Kumar. He is assistant professor in Department of General Medicine, AIIMS Patna. And finally, Dr. Govind Prasad. He is associate professor in Department of General Medicine, IGMS Patna. So the outline of my panel discussion today will be the definition, the consensus and controversies in the diagnosis, the management plan, the role of oral hypoglycemic agents and role of insulin in gestational diabetes, nutritional counseling in gestational, and counseling for future prevention of GDM. So a little introduction about gestational diabetes. As we know, the prevalence of diabetes is increasing worldwide and also in our country, India. Since the prevalence of diabetes is increasing, the prevalence of gestational diabetes is also increasing. And this is mainly due to greater urbanization. That is, the people are having a sedentary lifestyle, and higher maternal age and high BMI is also responsible for greater prevalence of gestational diabetes. A little about definition of gestational diabetes. First, there was an historical definition. It meant that any pregnant woman who was first detected with or recognized with impaired glucose tolerance in any time of her pregnancy was termed as gestational diabetes. But now the contemporary definition explains that any diabetes that is detected, or any kind of glucose intolerance that is detected beyond 15 weeks of gestation and with no clear present history of diabetes before the conception. So this is the more contemporary definition of gestational diabetes. Pre-gestational diabetes is a condition in which diabetes usually antedates pregnancy. that the patient is already having type 1 or type 2 pregnancy, type 2 diabetes before the pregnancy. What are the major concerns about GDM? The major concerns that it has important maternal and fetal implications. Important maternal implications are increased incidence of preeclampsia, stillbirths, and the greater need for cesarean section in mothers. And the important fetal risks are the development of hypoglycemia in neonates, macrosomia, a large baby, and the newborns usually suffering with respiratory distress and birth injuries during labor. And the risk to both mother and fetus or the baby lies that there is an increased incidence of future type 2 diabetes. So we know one very good thing about gestational diabetes, that a significant number of patients can be treated satisfactorily with medical nutrition therapy and lifestyle intervention, that is regular physical activity and medical nutrition therapy when glycemic controls can be achieved with diet alone. So there is no need of any pharmacotherapy. But still there are 20% of cases which may need pharmacotherapy, which includes oral anti-diabetic drugs and insulin. So today we'll start the panel discussion. So there is a universal consensus that screening for gestational diabetes is important. But there is ongoing debate about the different lab methods that can be used, different diagnostic thresholds of glucose to define gestational diabetes, and the timing of doing this diagnostic test. So I want to ask Dr. Shyama, how do you face these challenges in your clinical practice? So what are how do you address the areas of consensus and controversies of diagnosing gestational diabetes in your clinical practice? Dr. Shyama.
So regarding consensus, whenever the patient comes for a prenatal visit, so first visit there is a consensus that we have to do screening at 24 to 28 weeks. So the screening has to be done. Controversy is कि कब करना है, when it has to be done. Like if she comes at first prenatal visit and there are risk factors present. As per guidelines, if risk factors are present, then early pregnancy testing, which is less than 20 weeks, we do early pregnancy testing. If risk factors are not present, then screening is done at 24 to 28 weeks. If in early pregnancy it comes positive, standard management for diabetes, and if it comes negative, we again screen for at 24 to 28 weeks. So according to ADA and ACOG, it's early pregnancy is done in patients with risk factors. There is insufficient evidence to having a universal screening in early pregnancy. Then these are the risk factors like BMI, higher BMI with early history of gestational diabetes, patient with hypertension, certain ethnicities, patient having a higher lower HDL and a higher triglyceride level, with physical inactivity, polycystic ovarian syndromes, and other clinical conditions which are having insulin resistance like obesity, patient with acanthosis nigricans, and having previous baby with a higher birth weight. Even older pregnancy, that is more than 40 years of age, it is still recommended to do early pregnancy testing, that is less than 20 weeks. We need to test for diabetes. Now, the more universal screening is followed at 24 to 28 weeks. Now the next controversy is, okay, we have decided that we have to screen pregnancy at 24 to 28 weeks universally. It is not risk-based. Risk-based is early pregnancy. Now the controversy is which test to be used. Either various bodies have recommended various tests. It is a one-step or a two-step test. One-step test is post 75 gram glucose 2-hour test, and here diabetes in pregnancy study group in India has advice for 75 gram OGTT 2 hours. Anyone, and it is fasting and non-fasting, which is actually currently being followed, also recommended Foxy India. That is more than 140 if it comes, it is gestational diabetes mellitus. But it actually has a more, it catches more patients, so there is likely that there will be more financial constraints and other problems. So that is why in India, though it is being considered, there are other bodies who consider a two-step test. A two-step test is like one you give a 50 gram glucose, and if it is higher, then we go for a second test, that is 100 gram glucose and 3-hour test. So this is currently there are two. So the consensus is next. Consensus is mainly we have to do screening in all pregnancies. We prefer screening in between 24 to 28 weeks. At 24 to 28 weeks, universal screening is preferred, and 75 gram OGTT is widely accepted as a diagnostic test by many bodies. And it is recommended that you have to follow your local body guidelines for this type of test, because there is still controversy regarding that. And the controversies are, so major controversy as discussed, whether we should do early pregnancy screening. Currently it is risk-based. Whether we should do a universal or risk-based screening at 24 to 28 weeks. Currently it is universal screening at 24 to 28 weeks. And whether we should follow one-step versus two-step approach. It is advised that you have to follow the local body guidelines. Currently in India, they are following one-step test. Thank you.
So Dr. Sharma, which guidelines we are following?
We are following here like Foxy, Dipsy.
So one-step test?
One-step test, 75 gram, 2 hours post 75 gram glucose, non-fasting, fasting.
So
regardless of fasting or non-fasting status, if it is more than 140, it is termed gestational diabetes mellitus.
So the 2-hour reading is taken?
2-hour reading
or
is
we
taken.
need to take the mean of all the 3 readings, that fasting?
No, they are taking one reading only for ease of doing, and also you have to do at peripheral level also. That is why that recommendation has come to pick up more patient and to avoid complications of GDM.
Okay. Thank you for the comprehensive explanation by Dr. Sharma. Now we move from the diagnosis to the treatment part. We are moving to an area of great interest and increasing debate about the use of oral anti-diabetic drugs in gestational diabetes. So Doctor, the next question goes to the next panel, Dr. Jameshwar. I want to ask that, is there any role, evidence and safety of oral anti-diabetic drugs in management of gestational diabetes?
So when we're planning for management of GDM, we must have to set up some goal of management, because only not is the part to maintain the blood glucose level. Here our focus is also on the baby's healthy life of the woman or mothers and healthy fetus, and also other the postpartum period also. What will be consequences? Based on which there is some consensus about this. Fewer of the oral drugs are here to maintain some uses. Like first is the metformin. One of the big one is improved the body sensitivity to insulin and can reduce the resistance to insulin. So it may have some controversial about placental transport or what will be effect on the baby. So there, based on which we have the study suggested that it can manage the weight also. So there is some debate about the effect on baby. And second is the glyburide, one is sulfonylurea, which stimulated the pancreas to release more insulin. But it also crosses the placenta, and its effect on fetus is some not big way. It incited the fetus pancreas also, which lead to a lot of complications and further deranges on the microsomia or preterm death may be occurs. Next one, based on which when you compare with the insulin, which is now the preferred, has some effect on metformin, it is a reasonable alternative. There is less preferred is the glycerides. Placental transfer, insulin has minimum transfer, but metformin is highly, equally to mother and equally to the fetus. Glyceride has low to moderate, but it sensitive the pancreas of the fetus also, which has some consequences. Hypoglycemia. Glyceride has the high risk for hypoglycemia. Maternal weight gain. Here, metformin is even considered as better than to insulin to maintain the maternal weight gain. But there is no risk for diabetics. Failure rate. Metformin has only one drawback here, which is the highest failure rate. And when long-term safety, here insulin has the established long-term safety. And recent diabetes care, 26 edition has also written that metformin is nearly equal now to insulin. So we can add the metformin in the primary condition, and we may in screening the few weeks. If there is some failure rate, we can switch to insulin. But now glimmerite had the addition of the latest ADA.
Thank you, Dr. Jameshwar. Is there any other anti-diabetic drugs in the pipeline which is showing any evidence of benefit in gestational diabetes? Or we are using only the glibenclamide and the metformin?
Glibenclamide has the long way history. Now it is obsolete.
Right.
At present, metformin is preferred first line.
Okay.
Off level, metformin is the preferred now. If there found some failure rate, we may switch up to insulin. And still we are debating for upcoming newer drugs, which may be beneficial, but there is no enough data to establish they are safe in pregnancy or not.
Thank you, Dr. Jameshwar. Now we move to the next panelist. Now, while oral drugs are being increasingly discussed, but insulin remains the cornerstone of therapy in gestational diabetes. I would like to ask my next panel, Dr. Jyoti Dinkar, can you outline the role of insulin in the management of gestational diabetes, including the indication, timing, and practical considerations?
Good morning to all of you. Insulin plays a key role in the management of gestational diabetes mellitus, particularly when lifestyle modification and other oral anti-diabetic agents are not effectively controlling the blood sugar level. Insulin is a standard key in the management of gestational diabetes mellitus, and it is effectively control the blood sugar level and also prevent the complications in the mother and the growing fetus. So why insulin is needed in gestational diabetes mellitus? Because pregnancy naturally causes increased insulin resistance, particularly in the second and third trimesters due to hormonal changes. Persistent hyperglycemia can increase risk for the fetus that leads to macrosomia, neonatal hypoglycemia, increased risk for future obesity and diabetes, and in the mother, preeclampsia and birth complications. So insulin regimens for gestational diabetes mellitus are often basal bolus that simulates physiological secretions, and it is designed to maintain both fasting and prandial blood glucose within target range. So what is the outcomes and importance of the use of insulin? So use of insulin in GDM reduces risk of fetal macrosomia and helps achieve newborn normopexy. Rapid, effective blood glucose control with insulin can significantly decrease short-term pregnancy complications as mentioned in earlier slides, and may have long-term benefits for offspring metabolic health. So insulin is typically discontinued just after delivery, as the insulin resistance caused by pregnancy hormones resolves, but close monitoring is essential for both mother and baby postnatally, because in large proportion of the patients in the mother, they are more prone to develop frank diabetes in future.
Thank you, Dr. Jyoti Dinkar.
So in summary, insulin is vital for achieving glycemic targets in GDM when non-pharmacological measures are inadequate, ensuring the health and safety of both mother and fetus throughout the pregnancy.
Thank you, Dr. Jyoti Dinkar. Can you tell me how do we calculate the insulin requirement in pregnancy, and when do we need to start it?
Insulin, just we have to tight control the blood glucose in the pregnant females, so that it cannot lead to the mother-related complications and fetus-related complications. So we have to target the blood sugar level below 130 milligram per liter.
Thank you. Now we move to the next panelist. Now, beyond pharmacotherapy, medical nutrition therapy is very important. It remains the foundation for the management of gestational diabetes, and it also determines the glycemic control properly. So, our next panelist, Dr. Narendra Kumar, can you explain the role and key principles of nutritional counseling in the management of gestational diabetes?
Thank you, sir, for giving me the opportunity. So, so far nutrition is concerned for the management of gestational diabetes. Basically, it is the cornerstone of management in gestational diabetes. So, what are the goals? Why do we need to have medical nutrition therapy? So, basically, the goals are to maintain the euglycemia. So, blood targets were already discussed by the previous speakers. Basically, it ensures to ensure the adequate maternal nutrition and to gain appropriate weight gain, and to support the optimal fetal growth, and also to prevent the complications, fetal complications like macrosomia and neonatal hypoglycemia, and to prevent the long-term complications in the baby like diabetes, type 2 diabetes and obesity. Basically, what should be the dietary principles? So basically, carbohydrates should constitute 40 to 50% of the daily caloric requirement. Complex carbohydrate is preferred, and the source of which are basically the whole grains, legumes, and vegetables. We should prefer for low glycemic index carbohydrate. Simple carbohydrates should be avoided. The meal patterns, there should be at least 3 regular meals with 2 to 3 small snacks, and 1 late evening snack is preferred because it helps to prevent the nocturnal hypoglycemia as well as the early morning ketosis. What food to encourage and what to avoid? The food that should be encouraged are we should encourage for whole grain foods, millets, pulses, and vegetables, and fruits with low glycemic index. We should encourage for lean proteins, the source of which are basically milk, curd, eggs, legumes, and to avoid the red meat. We should avoid for desserts and to limit the beverages. Refined carbohydrates should be limited, and so basically, next. So the key strategic for the counseling, nutritional counseling are basically nutritional counseling should be individualized for each patient, preferably by a registered dietitian. It should be keeping in the mind of the baseline BMI of the patient as well as cultural background of the patient, and of course the affordability. There should be regular blood glucose monitoring, and each patient should be given nutritional education by a registered dietitian, along with lifestyle modification should be promoted. The recommended daily physical activities is up to 150 for 150 minutes per week with moderate aerobic physical intensity. Multidisciplinary approach should be applied for the proper optimum management of the diabetes in pregnancy. So we must include the obstetrician, dietitian, as well as endocrinologist. So in the last but not least, the nutritional counseling is the center of the management for the gestational diabetes, and it helps to prevent both short as well as long-term complications in gestational diabetes. Thanks.
Thank you, Dr. Narendra.
what is the advantage of giving multiple meals, small meals in
So basically
patient?
yes.
And what is the importance of giving a bedtime snack is also, I think, preferred.
So the main purpose of spreading the meal frequency is basically to reduce the postprandial hyperglycemia, and the late evening snacks helps to prevent the nocturnal hypoglycemia as well as morning ketosis.
Yeah. Well, thank you. Now we know that after pregnancy, the glucose levels usually normalizes, but a female who suffered with gestational diabetes have a high future risk of developing type 2 diabetes. So further preventive counseling is very important in the management line of gestational diabetes. So I will invite the next panelist to talk about what are the counseling that is required for future prevention of gestational diabetes. Dr. Govind Prasad.
Thank you, sir, for giving me the opportunity. Good morning to everyone. I think most of the parts of the GDM have been beautifully covered by our previous panelists. So coming to the counseling part for future prevention. So why counseling is important? It is said that prevention is better than cure. And counseling the woman with gestational diabetes mellitus gives a critical opportunity to prevent the future metabolic disease. GDM increases the lifetime risk of type 2 diabetes mellitus by 7 to 10 fold increase. And it also increases the recurrence in next pregnancy by 30 to 50%. And apart from increasing the maternal risk, it also increases the childhood risk, including the childhood obesity and impaired glucose tolerance. So, what are the core counseling components? So, there are various components of of counseling like risk communication, postpartum OGTT, lifestyle modification including diet, exercise, weight reduction, breastfeeding support, pharmacological intervention and future reproductive planning. So coming to one by one, the first is risk communication. So it should be given in a clear, culturally sensitive and language, emphasizing the modifiable risk of future diabetes risk. The woman should be informed that although the glycemic level returns usually to normal postpartum, but the underlying insulin resistance remains persistent, which may lead to recurrence of GDM in next pregnancy, or it may lead to overt diabetes in future. Then comes postpartum OGTT at 4 to 12 weeks. So guidelines recommend that 75 gram oral glucose tolerance test should be done at 4 to 12 weeks postpartum, and thereafter the lifetime screening should be done every 1 to 3 years. Then coming to lifestyle modification, including diet, exercise and weight reduction. So the woman should be encouraged to take a balanced diet, including whole grains, vegetables and fibers, and reducing the complex carbohydrates, and reducing the refined carbohydrates and sugary beverages. And they should encourage for aiming at least 150 minutes of moderate intensity exercise in a week, along with the gradual postpartum weight reduction by 5 to 7%. Then comes to breastfeeding support. Evidences have shown that longer the duration of the lactation period, lesser are the chances of maternal diabetic risk. So the woman should be encouraged for exclusive breastfeeding for at least 6 months. Then comes for pharmacological intervention. If lifestyle modifications alone are insufficient, then metformin may be considered if impaired glucose remains persistent. Then future reproductive planning. So counseling must also address the future planning, including the safe and effective modes of contraception, and along with the optimization of glycemia and weight prior to the next pregnancy, so that the chances of recurrence of GDM in next pregnancy may be reduced. So effective counseling must include the multidisciplinary involvement, culturally adapted materials and repeated reinforcement. And if the women adopt these measures optimally, then the chances of recurrence of GDM in next pregnancy and the future diabetes burden may be significantly reduced. Thank you.
Very well said. Dr. Govind.
Is there any role of continuing with the insulin sensitizers like metformin after delivery?
If lifestyle modifications are alone are insufficient and impaired glucose resistance is persistent, then metformin may be considered. Okay. If lifestyle modifications alone are not sufficient, then metformin should be considered.
So we can we can have some takeaway messages after this panel discussion. So now it is clear that gestational diabetes is very common, and early and appropriate screening is very essential. Medical nutrition therapy is the foundation for the gestational diabetes management. Oral anti-diabetic drugs may be useful only in selected cases, but insulin remains the gold standard and the cornerstone treatment, gold standard treatment for gestational diabetes. But however, management of gestational diabetes must be individualized, and GDM does not end with delivery, and postpartum follow-up and future preventive counseling is very critical. So I thank all my panel members for the valuable insights and their practical expertise in the field of gestational diabetes. And I think everyone who is there in the audience, they can also take away these messages and can use them in the clinical practice. Thank you. Thank you. We end this session. If any questions, you have.
Thank you, sir. A very heartfelt thanks to all the panelists for the insightful thoughts and advice. Your advices do help us to have a more clarified vision on the topic discussed. For further proceedings, I would like to invite Dr.
Good morning, everyone present here. I warmly welcome all our respected guests, senior doctors, speakers, and participants to today's conference on the Diabetes RSSDI BIHAR chapter. I thank the organizing committee for arranging this scientific program and thank all of you all for taking out time for your busy schedule to join us. With this, I like to invite our chairpersons, Dr. Narendra Kumar sir, Dr. Pankaj Kumar, Dr. Afshar Ahmed, Dr. Shumit Kumar, and Dr. Brajesh Kumar. Sir, please come. With this, I am happy to invite our first speaker to begin the session, Dr. Pranshu Kumar, and the topic is the technology in insulin delivery from pens to pump.
Respected chairpersons and my seniors and my dear friends. My today topic is technology in insulin delivery from pens to pumps. Enhancing comfort, precision and control in diabetes management. First, I will discuss the historical background and evolution. In 1923, first isolation of insulin from pancreas. In 1960, introduction of modern insulin syringe for use. In 1980, first commercially available insulin pump was made. In year 2000, launch of CGM monitoring was done. In 2020, integration of insulin delivery with smart technology, that is era of AIDs came. Now the historical burden of insulin therapy. In 1920s, early injection involved large reusable metal and glass syringes, long needles leading to significant pain and infection risk. Multiple daily injections required constant vigilance and discipline. The primary goal of technology has always been to reduce pain, increase convenience, and mimic natural pancreatic function. Now, the convenience and discretion about the rise of insulin pens. In 1985, the first commercial insulin pen was introduced by Novo Nordisk, offering a revolutionary shift from vial and syringes. What was the benefit of using these insulin pens? First, the convenience, pre-filled cartridges and portability. Second, accuracy. It improved dosing mechanisms. Moreover, they reduced the pain, utilization of ultra-fine, short and disposable needles. Now, the era of modern pens. Introduction of smart pens with memory functions like recording dose, time, and having Bluetooth connectivity to our device. This is a picture of smart pen which has connectivity of Bluetooth with our mobile apps. Now, smart pens, their key benefit features. First, enhanced accuracy. They provide precise dosing to optimize blood glucose management. Second, they are user-friendly. Features intuitive interface for easy user operations and monitoring. Third, data tracking. Automatically logs insulin doses for better health insights. Fourth, connected technology. It integrates with apps for personalized diabetes management support. Advantage of using these smart insulin pens. First, health benefit. It improves the patient's outcomes through better adherence. Second, cost saving. It reduces long-term healthcare cost through improved control. User engagements. Increases patients' involvement in their diabetic care plan. And fourth, market growth. Expanding market with rising demand for advanced solutions. Now, the era of continuous infusion, the insulin pump. Insulin pumps are a small wearable device that delivers rapidly acting insulin continuously at a basal rate through a small infusion sets placed under the skin. In 1960s and 70s, early pumps were bulky, experimental. They were like backpacks. In modern eras, since 1990, modern pumps have come which are compact, highly programmable, offering precise fractional dosing so that they can even deliver 0.01 units even, and have a flexible delivery options. Their types are tube pumps, tubeless, patch pumps, for example, Omnipod. This is a picture of the insulin pumps which were used in 60s. They were just looking like backpacks. And these are modern days insulin pumps which are used nowadays. Now we will discuss difference between using pens and pumps. First, the pens. It has lower initial cost, no physical attachment required, simple to use, and suitable for many lifestyles. Whereas pumps, they reduce the number of skin pricks, overall highly precise delivery, improved glucose control, having greater flexibility with meal times and exercise. This is Omnipod with PDM or tubeless. Pod is a small device, freestyle meter built into handheld program. Patch pump Omnipod, their benefits. They have no tubings, they have automated infusion set insertion, they have lower upfront cost, smaller and more discreet, no siphoning or disconnecting. We can change site every 2 to 3 days. Considerations: they can't disconnect, bigger skin patch, less cannula choice. If trouble applying insulin device, insulin lost, higher disposable supply cost than traditional. Advantages of using pump therapy: better HbA1c improvement, less glucose variability, reduction in duration and frequency of severe hypo, 50% drop in severe hypo. Quality of life improves. Precise, they are very precise. They can deliver even 0.05, 0.25 or even 0.1 units when required. What are the clinical indications for using insulin pumps? Preconceptional planning and pregnancy. Frequent hypo or hypo unawareness. Where there is extreme insulin insensitivity. When patient having needle aversion, if patients having gastroparesis, early neuropathy or nephropathy, even we have choice in cases of renal transplant. Now we will discuss the artificial pancreas, AIDs, the hybrid closed loop system. What do we understand with hybrid, and let me explain, and closed loop system. Hybrid means patient has to perform, he has to feed how much units of glucose he has to take, what carbohydrate he has taken. So this system is hybrid, not only automatic. Patient has to do something. This is called hybrid. And what is closed loop system? Closed loop system means when glucose CGM senses the requirement, insulin is delivered. The integration of CGM with insulin pumps via smart algorithms. How it works? Real-time CGM data is used by algorithms to automatically adjust basal insulin delivery to keep glucose levels within a target range. Benefits of using AIDs: reduced hypoglycemia and hyperglycemia episodes, increased TIR, means time in range, more correct glucose, patients having more time having normal glycemia. This is called time in range, when their sugar levels are normal. Significantly reduce the management burden for the user. This is the modern day AIDs like Valitas, Vigo. This is Minimate 670G insulin pump, the first and only system that constantly self-adjusts to automatically keep sugar level in range based on how you live your everyday life. They have preset mode. They automatically adjust insulin delivery. They have easy insertion up to 7 days wear. Realistic expectations. They are tools, but not cure. We have to check our blood glucose. We have freedom, but still can't graze. Blood sugar will be in target more frequently, but not perfect. Moreover, they are a connected device. Challenges faced in insulin delivery innovations. Problem 1. Limited patient engagement with advanced delivery systems. Patients often struggle with device uses. Education on technology is frequently inadequate. Second problem, high cost associated with new delivery technologies. Many innovative systems are prohibitively expensive. Insurance coverage can be inconsistent or even lacking. Third problem, reliability issues with current AID methods. Device sometimes malfunction unexpectedly. Inaccurate dosing can lead to serious consequences. Now we should discuss the road ahead, that is future innovations which are coming in this era. Fully closed loop systems requiring minimal to no user input, that is automated meal bolusing. Dual hormone therapy, hormone systems, pumps that can deliver both insulin and glucagon. These are the new age AID having both insulin and glucagon channels, and nowadays they are in pipeline in US, and in few years they will be even available to even our country also. And they have beauty that when we use present day AIDs, we can manage the hyperglycemia. Sugar is rising, we increase the insulin and we reduce the blood sugar, glucose levels. But when we are having glucagon, we can even manage the hypoglycemia. When the blood sugar is, when we can increase more doses of insulin, and when we blood sugar goes lower level, then glucagon comes to support, and we can get even more consistent CGM report, and we can manage both hyper and hypo effectively. And now the smart technology, enhanced integration with smartphones and cloud-based data function for better clinical oversight. These are the wearable technologies for insulin delivery. First, smart pumps, and second is CGM, already discussed. Third is wearable device. Fourth is mobile applications, apps, and fifth is data analytics that have advanced algorithms that predicts insulin needs for users. Key takeaways. Insulin technology has moved from basic painful tools to discrete, intelligent devices that restores autonomy and improve the quality of life for the people of diabetes. Thank you.
Thank you, sir, for your nice and informative talk. Please take your seats. Now, invite our next speaker, Dr. Rajiv Kumar Jha, sir.
respected chairperson, my senior and my dear colleague. Topic is from nephron to myocyte, redefining treatment of diabetes. Why nephron to myocyte? Traditionally, we categorize diabetes complication into microvascular and macrovascular. But in reality, vascular damage starts from very small vessels or capillaries of an organ like kidneys, nephron, to larger arteries or vessels of myocyte of heart. So, when we talk about diabetes, better way to understand diabetes from nephron to myocyte. Also, thinking in terms of nephron to myocyte highlights how early vascular damage of kidneys glomeruli can set the stage for larger vessels, vascular damage and cardiac damage. So this nephron myocyte crosstalk is central to the understanding of modern day diabetes as a systemic cardiorenal metabolic disease rather than isolated glucose disorder. This highlights how early microvascular damage from kidney can set the stage for macrovascular damage of heart. Coming to the pathology from organ disease glucose to organ network, various metabolic stressors like insulin resistance, hyperglycemia, dyslipidemia, oxidative stress, they causes endothelial cell damage, and this endothelial cell damage along with renal impairment like increase in glomerular hyperfiltration, loss of basement membrane thickening and loss of podocyte leads to albuminuria and causes progressive CKD. So along with this renal impairment and systemic vascular injury, they further accelerates atherosclerosis, heart failure and myocardial ischemia. We know very well that CKD and cardiovascular disease coexist in patients of diabetes and making them high-risk cardiorenal phenotype that increases hospitalization and mortality. Further, this reduced nephron mass leads to fluid overload, uremia toxin to accumulate, anemia and increased neurohormonal overactivation, which burdens the heart and accelerates cardiac remodeling. Conversely, heart failure reduces renal perfusion, venous congestion and decreases GFR and causes chronic kidney disease. So what we learned from the past? Diabetes is an ancient disease and before discovery of insulin, treatment was extremely restricted carbohydrate diet. After insulin, longevity and lifespan of diabetic people increased and we learned to know about microvascular and macrovascular complications. In 1990s, major landmark trials published like UKPDS, DCCT, Accord and VADT, which shows despite glycemic control, microvascular complication improves, but there is no significant improvement in macrovascular complication. In fact, strict glycemic control can increase cardiovascular mortality. So we learned from past, early and moderate glucose control is good. Too aggressive control in high-risk patients may be harmful, and glucose control alone is not sufficient for cardiovascular protection. In 2007, Stephen E. Nissen published a meta-analysis and it raised serious concern about cardiovascular safety of rosiglitazone. Later it updated regulation. In 2008, US FDA imposed strict criteria to ensure cardiovascular safety for a newer diabetic drug. Since then, several cardiovascular outcome trials were conducted with DPP-4 inhibitor, insulin SGLT2 inhibitor and GLP-1 receptor agonist. Although all of these drugs indicated non-inferiority regarding major adverse cardiac events, SGLT2 inhibitor and GLP-1 receptor agonist provided unexpected benefit to cardiac events. The IMPA-REG outcome was the first trial with SGLT2 inhibitor, which demonstrated reduction in all-cause mortality due to cardiovascular causes. Also, there was reduced or decreased hospitalization for heart failure. This finding was consistent with all the trials of SGLT2, and this prompted investigation of heart failure in non-diabetic patients also. DAPA-HF was the first trial in chronic heart failure with reduced ejection fraction, which shows benefit in non-diabetic patient also. Further, it has SGLT2 inhibitor shows renal benefit as demonstrated in Credence, DAPA-CKD and IMPA kidney trial, with reduction in risk of composite outcome in terms of eGFR decline of 50%, persistent progression to ESRD, and improvement in microalbuminuria. So, throughout all the trial, SGLT2 inhibitor shows benefit in heart failure irrespective of ejection fraction and irrespective of glycemic index. Coming to GLP-1 receptor agonist, liraglutide was the first molecule of this class, which shows cardiovascular benefit in LEADER trial. Subsequently, once weekly injectable semaglutide in SUSTAIN 6 trial demonstrated reduction in MACE, and there was also renal benefit from semaglutide in FLOW trial. The conclusion of cardiovascular outcome trial of GLP-1 receptor agonist was its effect is mainly anti-atherosclerotic, independent of weight reduction, while SGLT2 inhibitor effect is mainly energy metabolism or change in hemodynamics. Though both molecules have different mechanism of action, they exert complementary action when used together in protection of heart and kidney. One more molecule is there, non-steroidal mineralocorticoid receptor antagonist, Finerenone, which further added a layer to cardiac and renal protection, especially in patients of albuminuria and diabetic kidney disease. So, these new molecules redefine treatment and makes pillar of targeted therapy along with RAS blocker. This is the glucose lowering therapy is changed to priority first approach. Cardiovascular and kidney risk reduction is the first priority, followed by weight management and achievement of glycemic control, and focuses on metabolic liver disease, along with healthy lifestyle and evaluation for barriers. This is adapted from new guideline, in which first goal is cardiovascular and kidney risk reduction. If patients have atherosclerotic cardiovascular disease or there is high cardiovascular risk, prefer GLP-1 receptor agonist or SGLT2 inhibitor. If glycemic index is not achieved, add GLP with SGLT2 inhibitor of proven cardiovascular benefit. In patient of heart failure and CKD up to eGFR 20, prefer SGLT2 inhibitor, and if glycemic control is not achieved, or if there is comorbid obesity, or if eGFR is less than 20, prefer GLP-1 receptor agonist. Now, second goal is weight management. ADA 2026 clearly mentioned weight reduction as a therapeutic goal of diabetes. We have very high efficacious drugs like semaglutide and tirzepatide. Next goal is achievement and maintenance of glycemic goals with metformin and other drugs. New focus is on metabolic liver disease, MASD and MASH. Agents with proven benefits are GLP-1 receptor agonist and dual analog and pioglitazone. So apart from medication, reassess patient every 3 to 6 months and evaluate the barrier. We should not forget foundational treatment, that is strict blood pressure control, targeting less than 130/80 by using ACE inhibitor or ARB. This is critical for both renal and cardiovascular health, and aggressive management of dyslipidemia is recommended. Now, this is key shift in diabetes treatment goals 2026. This is take-home message also. New treatment goal is shifted to holistic organ protective care. That is prevention of cardiovascular disease and chronic kidney disease, which are leading cause of death in people with diabetes. Medication prioritization with GLP-1 receptor agonist and SGLT2 inhibitor are now recommended for patients with established cardiovascular disease or high risk, and for those with heart failure or CKD, regardless of their HbA1c level. These drugs are called multi-organ protective drugs, not just blood sugar medication. Individualized glycemic control according to health status, age, risk of hypoglycemia and comorbidity. Keep HbA1c less stringent in older patients due to risk of hypoglycemia. This recommendation highlighted time in range, that is percentage of time spent in optimal glucose range of 70 to 180 milligram per deciliter. Emphasis on weight management and lifestyle is given in this recommendation, and remission as a goal. For many with type 2 diabetes, especially if diagnosed early, achieving disease remission through significant weight loss, while lifestyle, medication or metabolic surgery is now recognized and achievable goal. Specific lifestyle recommendation and physical activity is suggested. This guideline also introduced wider integration of technology, that is continuous glucose monitoring in broader population, not only in intensive insulin regimen. And as our previous speaker stated, automatic insulin delivery systems are strongly recommended for type 1 and some type 2 patients to reduce the burden of management and lower hypoglycemia risk. In short, 2026 goal is a proactive, patient-centered strategy that uses advanced tools and medication to manage the disease within a broader metabolic framework and preventing long-term complications. These are future emerging therapies. In spite of all these robust data, we are suboptimally using SGLT2 inhibitor and GLP-1 receptor agonist because of cost, therapeutic inertia, fear of side effects, and fragmentation between diabetology, nephrology, and cardiology. So, we need to protect organ first, weight reduction, and glucose maintenance thereafter. Thank you.
Thank you, sir, for your nice informative talk. Now, this is to inform you that the next topic is cancelled due to unavailability of a speaker. So go ahead to the next topic, management of hypertension in diabetes, and our speaker is Dr. S.P. Prasad. Sir, please go. Thank you, respected chairperson, and good noon to all of you. First, thank you to Dr. R.K. Jha, Rajiv Kumar Jha. He has debunked my burden, and I am highly thankful to organizing committee, Health Animal Conference, RSSDI BIHAR chapter, who has given the platform to stand before you. Now, coming to my job, my talk is management of hypertension in diabetes. Now, there is a critical intersection of two epidemics. This is management of hypertension in diabetes is really interlinked of two nexus, deadly nexus and having the deleterious impact of outcomes. So now two critical intersection of epidemics. Why this matters? Because hypertension and type 2 diabetes frequently coexist and creating dangerous impact over the patients and amplifies or intensifies the cardiovascular and renal morbidity. So dual burden is not merely additive, it's multiplication and fortification in the impact of the patient outcomes. So the pathophysiologic overlap between these conditions makes having the double impact of outcomes and deleterious impacts. So there is hypertension itself and diabetes. So this is the risk amplifies the risk of myocardial infarction and stroke, heart failure, and chronic kidney disease and retinopathies compared to the having a lone entity. So evidence-based imperative is there. The multiple landmark trials have demonstrated that early and aggressive blood pressure control in diabetes patients has the substantial reduction of both renovascular and cardiovascular or microvascular and macrovascular complications. The evidence clear that the BP management is critical and glycemic control in preventing long-term diabetes complications. So current guidelines from the American Diabetes Association 2024 emphasizes that individualized BP targets while maintaining the rigorous control of standard for the patients. Now, epidemiological burden, 50 to 80% epidemiological burdens of type 2 diabetes. The concurrent hypertension globally making the most common comorbidities. And 60 to 70% Indian population are the sufferer, and prevalence among the diabetic patients according to ICMR, Indian Council of Medical Research 2023 data. And there is twofold cardiovascular morbidity increased. The coexistence double the risk or intensify the risk coronary artery disease and ischemic stroke. So these aesthetics undergo the magnitude of the clinical challenges. The high prevalence of demands systematic screening protocols and proactive management strategies in all patients with diabetes, regardless of the age and disease duration. Now, pathophysiological mechanisms. There is driving mechanism hypertension in diabetes is essential, and rational therapeutic decision making the multiple interconnected pathways contribute to elevated blood pressure in this population. Now, insulin resistance, this is the culprit and leads to the created sympathetic overactivity and sodium retention, and consequently there is plasma volume expansion. And next is the endothelial dysfunction, reduced nitric oxide bioavailability impairs the vasodilation and leads to and promotes to vasoconstriction and RAS activation. Activity of renin-angiotensin-aldosterone system causes vasoconstriction and raised blood pressure. So clinical pearl and therapeutical clue. This mechanism explains why ACE inhibitors and RAS ARBs are particularly effective first-line agents in systolic hypertension and directly target to the RAS pathways while providing the additional renoprotective benefits. Now, blood pressure classification. According to ADA 2024 and ESC 2023 guidelines, clear-cut provided and a standard for the diagnostic, prognostic, and therapeutic initiation. So, category first, normal blood pressure, systolic blood pressure less than 120 and diastolic less than 80 mmHg, and just not elevated or 120 to 129 mmHg systolic blood pressure and less than 80 mmHg diastolic blood pressure, and stage 1 hypertension 130 to 139 systolic blood pressure and 80 to 89 diastolic blood pressure, and stage 2 hypertension more than 140 and more than 90 mmHg. So what is the target blood pressure? Target blood pressure is 130 by 80 mmHg according to ADA, and this target complies and balances the cardio protection and safety. Now, blood pressure control matters. Complication reduction for every 10 mm of Hg systolic blood pressure reduction leads to 12% reduction of diabetes complication, and stroke prevention. Adequate control of blood pressure leads to 44% risk reduction in stroke, and myocardial infarction reduction decreases the myocardial infarction risk with systemic blood pressure management and reduce the risk reduction at 21%. So, landmark UKPDS trial study had been revealed in 1998 demonstrated that blood pressure control is equally important as good as glycemic index control, preventing the diabetes complication. So, these findings have been replicated the multiple subsequent trials establishing the blood pressure management and demonstrated that the comprehensive care of diabetes and benefits extends across the spectrum, microvascular and macrovascular complications including nephropathies, retinopathies, neuropathies, and cardiovascular events. Now, diagnostic approach. First, confirm the diagnosis. The blood pressure reading should be taken multiple times and different occasions, and single readings is not suffice. So, out of office monitoring, utilize the home blood pressure monitoring or 24-hour ambulatory blood pressure monitoring to diagnose the difference. And third one, identify the phenotypes. The screening for the white coat hypertension raised in clinic and stabilized at home, and marked hypertension raised at home and stabilized clinic. And secondary causes. Evaluate the secondary causes of hypertension, including renal artery stenosis, primary aldosteronism, and pheochromocytoma in resistant cases, and Cushing syndrome and thyroid problem. So now, what is the baseline investigations? Renal function assessment for serum creatinine level and eGFR, and serum electrolytes and urine albumin creatinine ratio for microalbuminuria, and cardiovascular evaluation for fasting lipid profiles HDL, LDL, total cholesterol, VLDL, triglycerides, and lipoprotein. And in-organ protection and examinations, a fully dilated fundus should be examined for the diabetic hypertension and hypertensive retinopathies. Now, treatment targets individualized approach. General population, for general population, target should be less than 130 by 80 mmHg and applies to most adults with diabetes, hypertension, and target especially balances the cardiovascular protection and safety. And in elderly patients, more than 65%, 65 years of age, the target should be less than 140 by 90 mmHg. 140 by 80 mmHg, and less aggressive target reduces the orthostatic hypotension and fails to maintaining the benefits. And very cautiously use antihypertensive drug in elderly patients. It should be maintained less than 120 by 70 mmHg. And excessive blood pressure lowering may increase the risk of events without any additional benefits. So treatment targets should be individualized based on the patient age, comorbid conditions, cardiovascular risk, frailty, and tolerability. Now, lifestyle modification, foundation therapy for the management of hypertension and diabetes. So, weight management, assessment of shape of your body and weight management, achieve the body weight mass index BMI less than 23 kg per meter square for ASEAN cutoff. And even 5 to 10% weight loss significantly improves the blood pressure and glycemic index. And second one is the sodium restriction. Limit the dietary sodium less than 5 grams per day is mandatory for all adults. And avoid processed food, junk food, fried foods, and preserved foods. And dietary pattern, adopt a dietary approach to stop hypertension, like DASH diet, and enjoy with green leafy vegetables, whole grain fruits, and detox your body with hydrated water and lean protein, and avoid stress, anxiety, tension, confrontation, and perplexity. So, चिंता छोड़िए, चिंतन करिए. Now come to the preventive measures. Air pollution is mandatory and is burning issues in our vicinity. So physical activity, engage at least more than 150 minutes per week, and moderate aerobic exercise should be adopted either by jogging, cycling, or walking. And substance to be avoided, like limit to moderate alcohol consumptions, 2 packs per day for adult males and 1 pack for the women. Now, pharmacological management overview. Key principles: most of the patients of the hypertension require combination therapy with 2 or multiple agents, and the target for the achieve the target blood pressure and monotherapy and first line therapy ACE inhibitor or ARB should be given. Is preferred initially agents and cardiovascular renal protective effects, lowering the blood pressure and albuminuria. And combination therapy, add thiazide like diuretics and calcium channel blockers and second-line drugs, and triple therapy may be needed for the resistant hypertension. And titration, the strategic policy start with low dose and gradually escalate the dose after 2 to 4 weeks. Now, ACE inhibitor, first line renoprotective. The enalapril, commonly used agents, the enalapril 5 to 40 milligram in 1 or 2 divided doses, and ramipril 2.5 to 10 milligram once daily, and lisinopril 10 to 40 milligram once daily, and perindopril 4 to 8 milligram per day. So, what is the specific benefits? What are the specific benefits of the reduction in urinary albumin, creatinine, and microalbuminuria, and saving the diabetic nephropathy progression or halt the progression of diabetic kidney disease, and cardiovascular event reduction beyond the blood pressure lowering, and improve endothelial function. So, monitoring requirements: check serum potassium and creatinine baseline 1 to 2 weeks after initiation of the therapy, and repeat all creatinine increase, except the creatinine increase less than 3% from baseline, and monitor for hyperkalemia more than 5.5 milligrammes per liter, and assess for persistent dry cough, 10 to 15% incidence due to ACE-induced inhibition. Now, angiotensin receptor blocker ARB, the commonly used are the losartan 50 to 100 milligram, and telmisartan 40 to 80 milligram per day, and irbesartan, valsartan are commonly used. So, now come to the third line. Calcium channel blockers. The dihydropyridines calcium channel blockers are usually adopted, and primarily amlodipine 5 to 10 milligram once daily, and there is alternative to that, nifedipines long released 30 to 90 milligram per day, and ferrodipine 5 to 10 milligram per day. And advantage, there is a potent blood pressure lowering once daily dose, and metabolically neutral. Effect on no effect on metabolic glucose and lipid interfaces. So side effects are peripheral edema, 10 to 30%, and flushing of face, headache, and gingival hyperplasia very rarely. Now, follow overload management, use diuretics. Thiazide diuretics preferred. Chlorthalidone 12.5 to 25 milligram per day, indapamide to 1.25 to 2.5 daily. And loop diuretics, furosemide 20 to 40 milligram per day, or torsemide 5 to 20 milligram per day, reserved for the patient advanced DKD or end-stage renal diseases. And some metabolic monitoring. Thiazide loop diuretics may worsen the glycemic index and cause hypokalemia, hyponatremia, hyperuricemia, and monitor serum glucose, electrolytes, and renal function regularly, and consider potassium supplementation if needed. Now, beta blockers, selective beta blockers should be used. There is a beta blockers used in not a routine affair, so always use in post-myocardial infarction, proven mortality benefit, and heart failure with reduced ejection fraction, and coronary disease, anti-ischemic effect, and atrial fibrillation to rate control.
Sir, and sorry to interrupt you, sir. Sir, we have the time constraint, sir.
Okay, just let me finish. Now, hypertension management in diabetic kidneys. The RAS blockade is the key for the management, ACE inhibitor, and ARB monitoring. So, target blood pressure in CKD and maintain blood pressure less than 130 by 80 mmHg to prevent the nephropathy's progression. And avoid nephrotoxins like drugs like NSAIDs, ibuprofen, naproxen, and other. And monitoring protocols check the serum creatinine, eGFR, and potassium. So, type 1 diabetes and hypertension. Nephropathy is the primary diabetes. So, key clinical points: nephropathy drives the hypertension in diabetes, and start SIARB to check the microalbuminuria, and annual screening is essential, and renoprotection is the prime goal. So, non-pharmacological treatment of the patient educations and home monitoring and multidisciplinary actions like physicians, dietitians, educators. And now, come to key principles, and I'm going to summarize. This is the last slide for me. Principles for the clinical actions recognize the synergistic cardiovascular risk. Combination of hypertension and diabetes dramatically amplifies or intensifies the cardiovascular and renal complications beyond either the condition alone, and demanding aggressive evidence-based management, and target blood pressure should be less than 130 by 80 mm Hg. To take this, according to ADA 2024, balances the cardiovascular protection and safety, and RAS blockade is the cornerstone of a treatment, and combination therapy with when needed, when calcium channel blockers or thiazide like diuretics, when monotherapy is sufficient, and patient must require multiple agent therapy. And lifestyle modification is the key corner step to treatment for the management of hypertension, weight loss, and sodium restriction, physical activity, and consumption of moderate consumption of alcohol, and enhance pharmacotherapy and effectiveness, and improve overall the metabolic lifestyle. Thank you very much. Thank you, sir, for your very insightful and informative talk. Now the session is the question and answer session. So I request to our chairperson to please conduct the question and answer session.
Thank you all. My first question will be from Dr. Rajiv Bas. Boss, when do we consider changing oral hypoglycemic agent if the glucose is aptly regulated by, say, metformin and glimepiride? When should we design or monitor, and what should we convey to the patient that, look, this is it, we are changing the OHA of yours, and what will be the benefits for this? Is there any criteria?
Changing of oral hypoglycemic agents.
Like,
is it your question?
Yes.
In new guideline, the first priority is organ protection. So, if there is no comorbidity, metformin alone or with some drug, it is okay. But if there is risk of cardiovascular disease or evidence of atherosclerotic cardiovascular disease or evidence of heart failure, or there is proteinuria or CKD, you have to start SGLT2 or GLP-1 receptor agonist according to new guideline. Second, weight management is a separate therapeutic goal in the management of diabetes. And third is maintenance of glycemia. And fourth is management of metabolic liver disease. If there is comorbidity or all these factors, you have to consider eGFR, urine for protein, and BMI for prescribing oral hypoglycemic agent.
Any questions from the audience?
I think we are getting too late for the next session. So with the permission of the moderator, sir, can we close this session?
We have now come to the end of this session. I sincerely thank all our speakers for their clear, practical and informative presentation, and also thanks the audience for your active participation, question and attention throughout the session. So with this, thank you all and have a good day.
I would like to call upon Dr. Abhishek sir to felicitate our speakers and the chairperson. Dr. Pranshu Kumar sir. Kumar sir. Amit Kumar sir. Dr. Pankaj Kumar sir. Dr. Brajesh Kumar sir. Dr. Sumit Kumar sir. So moving on towards the last session for the day, I would like to call upon the next moderator, Dr. Avilok Kumar Jha, to take on the stage.
Thank you, sir. Good afternoon and warm welcome to everyone. So for our last session, we have some interesting topics lined up here. I would like to invite our panelists for the session. Dr. Milind Jha sir, Dr. Vivek Kumar Singh sir, Dr. Sushil Kumar Singh sir, Dr. Chandan Kumar sir, Dr. Abdul Wahab sir, and Dr. Dilip Kumar sir. I think only two of our panelists are here. Moving on, our first topic of the session is nutritional myths in diabetes, facts and versus fads. And I would like to invite on stage Dr. Abhilasa Singh ma'am to start the session. Ma'am, please.
Good afternoon to one and all, present in the hall, and myself Dr. Panache from Narayan Medical College, Sasala. I will be presenting the topic, nutritional myths in diabetes, facts and fads. Before going on to my topic, I would like to thank Team RSSDI for presenting the topic, And even before going deep into the topic given, I'll just like to go through what are the difference between the fad and the myth. Fad is basically a form of collective behavior or fashion that has become very popular over a period of time, and it's like mostly depending on interests like clothing, toys, and this decreases with time, and it is always in this becomes in trend because of the fact that it is thought to be novel or cool. On the other hand, myth is basically a traditional narrative it is providing by involving God, heroes, or supernatural that becomes a part of the society and custom and values, and that has some literary context or not. So coming up to the first, I'll be dealing with the myths and then I'll be dealing with the facts. So coming on to the facts that about the carbohydrate and the blood sugar is generally said carbohydrates are the enemies in diabetes. It should be avoided at all costs. On the other hand, while the American Diabetic Association recommends at least 45 to 60% of the total recommendation of the calories should come from the carbohydrate in the body. Total restriction of carbohydrate does lead to some reduction in the body weight, but in the long run it reduces insulin sensitivity and increases the cardiovascular risk. Second myth coming on to low fat versus healthy fats. Low fat or free fat diet had become a trend or was trending before in 90s. This said that low fat or no fat diet should be given. On the other hand, it is said that unsaturated fatty acids or omega-3 fatty acids are some studies have provided that they provide a protective, they have a protective role in the membrane stability and reduce the ROS and oxidation pathway that injures the endothelium of the cells. And ADA also recommends that 20 to 35% of the calorie calorie requirement of the person should come from the fats. Second myth about fruits and natural sugars. It said that fruits should be avoided because they contain natural sugar. On the contrary, fruits, apart from providing the natural sugar, they also provide us fibers, vitamin, phytochemicals that also protects the body against the insulin resistance. Excluding fruit and from the diet basically reduces the micronutrients that are needed for the body and also provides the nutritional deficiencies. Few fruits such as berries, apples also have a low glycemic index, so they should be included. And one of our speakers also said instead of cake you should cut a fruit. So that was very well said in aligning with this, busting this myth. Second myth was about artificial sugars. Artificial sugars have low glucose and aid to weight loss. Some sugars basically stevia leaves, and the other is oxides of glucose, that is xylitol and all. But this xylitol and all has shown to disrupt the microbiota, the appetite, and eventually it aids to weight gain. So the long-term risk, not studies are going on but have shown inconsistent association with cardiovascular risk. So moderation should be done depending upon the need of the patient, and priority should be given to water, unsweet tea, coffee, and avoid over resilience on it. Third is glycemic index. This one term glycemic index is always talked about. Basically glycemic index is the amount of blood glucose that is raised after having a food. So it's basically scaled between 1 to 100. So glycemic, when you go for glycemic index, what it does is it ignores the portion of carbohydrate that is included in the meal. So high glycemic index food and low amount of carb can have same glycemic index as the that of low glycemic index food having a large amount of carbohydrate. So focus should be given quantity and quality of carbohydrates rather than glycemic index alone. So use of glycemic index should always be a secondary guide, not prioritizing it. Fibers, grain, food, a balanced diet is more or less better. Second, carb counting. This it has become recently in trend that what are the amount of carbohydrates you are taking, what is this. Carb counting is good, and if you stick to it, it's good. But it's a very tedious process. Practically, application for the clinical patients is not very relevant. So, choosing a better lifestyle, having a diet basically consisting of many diets are there, like Mediterranean diet, DASH diet, or a plate models are better for patients also to understand also, and for a practical application also. So key should be given a consistency of and calorie intake. Third is myth is intermittent fasting automatically reduces the blood glucose level. So coming to intermittent fasting basically says 18 hours of fasting and then 8 hours of eating. So that is fine. Some trials have shown improved sensitivity. But if it is, again, patient is on oral hypoglycemic agents such as they experience hypoglycemic episodes. Intermittent, it can show rebound hypoglycemia also. Intermittent fasting should be started in patients, especially diabetics, having medicines under a medical supervision. And 24 hours glucose, if it is monitored, and nutritious meal is again combined with a balanced diet, it can have a better feature. Then fibers. Again, a very myth is there that high fiber supplements alone can replace the dietary fibers from the food. This is again, what do you say, a myth, like you don't have to give a dietary supplement for fibers. Dietary fibers alone can be sufficient if it is planned properly, because the main drawback with supplements with fibers is that it hinders the absorption of nutrients and medicines also. So it should be planned carefully. If dietary fibers are sufficient, then no added supplement should be given for the dietary part, fibrous part. And then again a supervision, if it is done, it's going to give a better outcome. Then about antioxidants. Vitamin C, the most commonly known antioxidant. It is said vitamin C and other antioxidants can lower the HbA1c levels. But what the meta-analysis has shown has very inconsistent level of glycemic control. And evidence show that higher vitamin C levels has in fact impaired the insulin sensitivity in long run. So adequate antioxidant intake with a variety of diet is recommended, but only over-reliance on antioxidant does have counterproductive effects. Then low carb diet again in long-term management can alone see it. It's not giving very beneficial effects. Yes, it does show some good results in weight loss and drop in HbA1 level, but it is in a very short span. It is not very consistent, because low carb diet patient also cannot comply with it, and so it should be outweighed. In fact, a balanced diet or a Mediterranean kind of a diet is going to be more beneficial for the patient in terms of cardiovascular risk, weight gain, and glucose for the glucose level. And coming to simple sugar, diabetes, then again a myth goes that diabetes diet must exclude simple sugar exclusively, entirely. So simple sugar, basically, where does this simple sugar come from? It basically comes from dairies, fruits, and even some vegetable. Removal of all these can decrease the dietary nutritional density of the macronutrients that are needed. And natural sugar is fine if given in small portions. Then again, it should not consist of more than 10% of the total calorie requirement of a person or a diabetic individual. Then again, a myth about late night eating is eating after midnight raises blood sugar level. This is again a myth because insulin does have some studies show circadian rhythm or influence sensitivity, but overall calorie load is what is going to raise the blood sugar level, not the time of eating. So if a person is eating a late night diet, he should have to choose the food that he is having it, like the glycemic, depending upon the glycemic index, should be high fibers and avoid refined flours or sugary carb diets. Favorite food should be avoided. Again, people with diabetes usually like to have some favorite food as sweeteners. That totally cannot be cut out, but again, it should be moderated, focusing on the pattern of individual and the exercise which he is doing, the lifestyle modification. Nutritional fats are the recent trends what have been seen in nowadays are, first is keto diet. That consists of very low carb and high fat diet. Core principle is more than 20 to 50, less than 20 to 30 per gram of this carbs are given in this, and more of the fat calorie requirement is met by the fat. So typically this meal consists of meat, egg, butter, etc., which is providing the more fatty portion. Short-term HB and weight is benefited. The weight is reduced and HbA1 is also reduced, but in long term it shows to have deleterious effect on the whole prognosis. So who can be benefited from this type of diets? They can be type 2 diabetes mellitus patients, but then again it should be in type 1, it's going to increase the risk of diabetic ketoacidosis. Second, Mediterranean diet. This is basically emphasizes more on grains, whole grains, nuts, olive oil, fish, and other typical food. And so, with this kind of diet, consistent lowering of HbA1c is seen. It has also shown in improvement in lipid profile and long-term reduction in cardiovascular risk. So what are the risks of this kind of diet risk? Moderate carbohydrate control is again needed. Who might be benefited? Both diabetes type 1 and type 2 diabetes mellitus patients are benefited, and if it is aligned with the recommended diets by the American this association, then it can be beneficial. Then coming to vegan diets. Vegan, again, what it is done is no animal products, only plant-based food is given. So evidence does show that it is reduced HbA1c level and weight gain and cardiovascular risk marker. So this kind of food basically consists of legumes, fruit, vegetable. The downside of this is, as no animal products are included, vitamin B, omega-3 fatty acid and protein insufficiency can be precipitated if not planned properly. Who might be benefited? Both type 1, type 2 diabetes mellitus patient can be benefited, but again nutritional monitoring of these iron vitamins should be done properly. Juice cleansers or raw foods. Core principle, basically only juice is given or raw vegetable is given. Secondly, typical vegetable sprouts are given. Evidence, little or no evidence of lasting glycemic control is seen with this type of diet, and a calorie restriction is also provided. So there can be a nutritional gap and risk of hypoglycemia in patients with again having medicines, or possible whenever the patient is going to again have it, a spike of glycemic index can be seen. So who might be benefited? Not exactly can be said, has to be, generally it is not recommended for diabetes patients because they are already having certain risk factors, and giving only one type of fruit or only juice can spike the, juices can in fact spike the glycemic index. So it's basically not advisable for diabetic patients. Then again comes with high protein. In this, the core principle is more than 30 to 35% of calorie requirement should come from protein. Typically, what does this type of food contain? Egg, dairy, soya, legumes products. Evidence show moderate improvement and satiety is also there in patients, so they can comply with this type of diet. What are the risk factors for this? Excessive protein can lead to precipitate stones, renal stones because of and may lead to lowering the demand of insulin. If he is having insulin, then again monitoring has to be seen. Who can be benefited? Caution has to be taken in type 2, and insulin reduction can be seen in type 1 diabetes mellitus patients. Then detox or clearing, that is core principle, it eliminates the toxin via herbs or chemicals or restrictive diets. So no evidence or credit has been given to such type of a diet, but it does have a, because of the use of the things that are thought to be anti-toxins or given, the chemicals can precipitate renal failure, and nutritional deficiencies plus electrolyte imbalances can also be shared. So it's usually not advised, detox diet is not advised for any kind of diabetes patients. No added salt diet is again one of the whole food and no added salt. Typically, this will consist of fruit, vegetables and whole grains. Evidence has shown, because of no salt is given, it does have some benefit in hypertensive patients with controlled glycemic index. Risk, there can be a risk of electrolytes, because salt is totally put off from the diet or the plates. So beneficiary effects in hypertensive patients, it can be seen, but again it has to be given under strict monitoring. So before concluding, I'll just like to say two things: that a balanced diet has to be given, and anything given to diabetic patient cannot be given blindly. It has to be given under recommendations. Thank you.
Thank you very much, ma'am, for wonderfully explaining the all nutritional myths and facts. So for the next session, we are moving on to neuropathy management, pain control and regeneration of, and I would like to invite Dr. Abhijit Kumar sir to start this session. Thank you, sir.
A very good afternoon to respected chairpersons, faculties and all the delegates assembled here. I am thankful to the organizing committee for giving me this opportunity. So I have to speak about neuropathy management. So if we define neuropathy, it is defined as a neurodegenerative disorder which affects the somatic and or autonomic peripheral nervous system in the context of diabetes mellitus without other secondary causes of peripheral neuropathy. It is important to rule out the other causes. Diabetic neuropathy can also affect the autonomic nervous system and the GI tract. We must remember that this is the only microvascular complication which cannot be reversed as of now. The other two, nephropathy and retinopathy, can be reversed through treatment. So what is the epidemiology of diabetic neuropathy? The pooled global prevalence of painful diabetic peripheral neuropathy stands at 46.7%. And this study was done on almost 32,000 individuals in India, and in India the prevalence was found out to be 39.3%. We have many of our patients who have the diagnosis of neuropathy at the first visit when they are diagnosed with diabetes mellitus. So what are the risk factors contributing to the development of diabetic neuropathy? Advanced age, long-standing diabetes, uncontrolled diabetes, hypertension, obesity, peripheral vascular disease, smoking, dyslipidemia, excessive alcohol consumption, and positive HLA-DR3 or 4 genotype. So what is the pathophysiological mechanism behind the development of diabetic neuropathy? We know that DSPN is the most common type of diabetic peripheral neuropathy. So we have loss of myelin fibers, there is injury of the unmyelinated nerves, and axonal atrophy, which is manifested as disturbances in the nerve conduction velocity and abnormal sensory function. All these four factors are contributory: hypoglycemia, dyslipidemia, insulin resistance, and microvascular disorders. So here we can see that these patients have axon loss, myelin loss, and neuron apoptosis. There are multiple pathways which are involved in the development of diabetic neuropathy, and some of these pathways are the source for future research for development of appropriate treatments for the same. So we have the protein kinase C pathway, polyol pathway, the AGE pathway, the hexosamine pathway, the PARP pathway, insulin pathway, and the other pathways. So what happens is that there is sorbitol and there is decreased production of myoinositol, and there is decrease in the sodium potassium ATPase activity, which decreases the nerve conduction velocity. We also have accumulation of the advanced glycation end products and the reactive oxygen species. So what are the symptoms of neuropathy? The patient can present with various symptoms like paresthesia, numbness, or debilitating pain. The patient may be at increased risk of falls. What are the complications which a patient of diabetic neuropathy can have? Untreated neuropathy can lead to ulcer formation, which in turn can lead to infections and sepsis, which can be life-threatening. Also, a lot of our patients have to undergo amputation because of diabetic neuropathy. So how do we diagnose diabetic neuropathy? It is basically a clinical diagnosis. The reliance on tests should not be there. But first we have to rule out the other causes of neuropathy like thyroid disorders, B12 deficiency, the presence of coexistent chronic kidney disease, and drug-induced neuropathy, which can occur with antiretrovirals or chemotherapeutic agents. So ADA recommends these following tests for small and large fiber assessment. For small fiber function, we have pinprick and temperature sensation, and for the large fiber function, we have the vibration perception, proprioception, and what we can use in our daily OPDs, the 10-gram monofilament testing and ankle reflexes. It is important to incorporate these tests in our routine clinical practice because ADA recommends that we should do neuropathy screening once in a year and at the time of diagnosis of first diabetes mellitus event. So we should subject our patients to these tests so that we can identify neuropathy early and initiate timely treatment. These are the scoring scales. We also have the use of in vivo confocal microscopy and nerve conduction studies which should not routinely be undertaken. Skin biopsy should sparingly be used. So what are the current treatment options we have for diabetic neuropathy? As I have said, this is still not a reversible phenomena, so the current treatments, they only focus on symptom relief. They are unable to halt or reverse the progression of the disease. So we have to identify these patients through regular and early screening. We have to assess the need for pharmacotherapy. Not all of our patients are going to need pharmacotherapy if the pain is mild, because pharmacotherapy is only directed at symptom relief. It has to be a shared decision making between the patient and the caregiver. It is also important to take care of the mental health of our patients, as the debilitating pain can lead to depression and low quality of life. So these are the currently available pharmacotherapy options. We only have 4 molecules approved by the ADA. That is amitriptyline, pregabalin, tapentadol, and capsaicin. So these form the first line therapy. Apart from that, we have nortriptyline, duloxetine, gabapentin, we have tramadol, but tramadol cannot be used as maintenance therapy. It only has to be given as short-term rescue therapy. We have the topical agents like capsaicin cream and lidocaine patches. In one study, lidocaine patch was found to be superior to pregabalin. Then we have the anti-inflammatory supplements that is alpha-lipoic acid, B12 and omega-3. They support nerve healing and reduce the oxidative stress. We have the microcirculation enhancers, that is the PGE1, pentoxifylline and chalidogenase. They improve the microcirculation by decreasing the blood viscosity, and they enhance the erythrocyte flexibility. This improves the nerve conduction velocity in these patients. We have the metabolic enhancers, that is acetyl L-carnitine, which improves pain reduction and nerve fiber regeneration. In this table, I have tried to summarize that which of the molecules are placed at number 1 position and number 2 position in the different guidelines. So I have already stated that the number 1 agents are the tricyclic antidepressants and SNRIs, apart from caspation patches and short-term rescue therapy with the opioids. Now, this is a very controversial area, whether we should start monotherapy or combination therapy from the first day. NICE guidelines tell us that we should go for monotherapy. We either start pregabalin or duloxetine, and if one agent is failing, then we add the other or we even replace it. But ADA says that we can go for concomitant dual therapy from the beginning only. So to settle this debate, a systemic review and meta-analysis was done. So it was found that the combination of gabapentinoids with tricyclic antidepressants or SNRIs was associated with a greater reduction in pain if you compare it with monotherapy. But this difference may not translate into a clinically important one. So again, it is left to the discretion of the treating clinician whether to go for monotherapy or dual therapy. Now what about the role of aldose reductase inhibitor? Ipalristat has been shown to give promising results, but we still don't have this molecule incorporated in the guidelines. It is an old molecule with proven safety record. What are the newer therapies? Microgabalin is a very promising therapy. It is again a gabapentinoid. It also acts like the pregabalin and the gabapentin on the alpha-2 ligand, alpha-2 delta subunit. But the potency at this receptor for this molecule is more if you compare it with pregabalin. Then what about the sodium channel blockers? So among the sodium channel blockers, this molecule, tetrodotoxin, it selectively inhibits the specific isoforms of sodium channels. So there are 9 known channels, out of which 6 are sensitive and 3 are resistant. So this one, sodium 5 1.7 isoform of the sodium channel, this is the most promising one, and this is an area of current research among the researchers. If we inhibit this channel, then it leads to complete pain insensitivity. So if we are able to target this channel, we might have a molecule which can actually lessen the pain of our patients. Now, we do not have pathogenesis-based therapies as of yet. We are only offering symptom relief to our patients. So, what about the role of GLP-1 agonists? We all know their wonderful role in weight reduction and some other pleiotropic benefits. They also lead to a robust reduction in the HbA1c. Do they have a role in treating diabetic neuropathy? Well, directly they do not have any role in treating diabetic neuropathy, but they can prevent new neuropathy via decreasing the stress on the vasa nervosum. They decrease the reactive oxygen species production and decrease the vascular cell adhesion molecule 1 expression. They also prevent the endothelial inflammatory response. So, regarding their role in nerve repair, there was a study done on diabetic rats. They were trialed on 1 nanomole per kilogram per day dose of extendin 4, which is a GLP-1 agonist, which is found endogenously in Gila monsters. So, we had the treatment arm and we had the placebo arm. After 4 weeks of treatment, there was higher perception threshold for pain in the treatment group, while the experimental group maintained their initial threshold values. So after the end of the experiment, these rats, the immunohistochemical staining of the nerve fibers were done, and it was found that the extendin 4 treated rats, the Schwann cell apoptosis was prevented and myelinated fiber size was maintained. So this presents a potential treatment for nerve repair in diabetic neuropathy. What about the role of SGLT2 inhibitors? Again, we do not have very robust evidence, but we have promise with certain molecules. This trial with dapagliflozin is currently undergoing, and regarding empagliflozin, the trial has shown potential benefit in diabetic peripheral neuropathy. For canagliflozin, more studies are needed. These are some molecules which are still not widely adopted, but they do show promise, and some of them are showing positive results. So we have got positive results with path inhibitors, that is actovegin. Apart from that, we are having an approved drug in China from 2024, which is the HSK 16149. Apart from these, all other molecules, that is the PCK inhibitor, riboxystorin, then the EPO analogs, then AAK1 inhibitors and microbiota therapy, they do show promise, but more research is needed. What about the non-pharmacological treatment? There are definitely some non-pharmacological treatments which exist for the treatment of diabetic neuropathy. Acupuncture is one of them, which has shown very strong evidence. Then we have the spinal cord and the peripheral nerve stimulation. They can also be used in such patients. So we have the electrical stimulation devices which modulate the pain signals and they improve the functional outcomes in these patients. We have the transcutaneous electrical nerve stimulation, and in electrical spinal cord stimulation, the electrodes are implanted between the T9 and T11, which results in a pain relief in more than 50% of the patients. Physical therapy and rehabilitation also has an important role. This includes balance training, gait training, and strength exercises. We have to reduce the chances of falls in these patients. Then what about cognitive behavioral therapy? This is also very important. It will address the psychological distress in our diabetic neuropathy patients. Surgical decompression is not yet an approved treatment, but it has been tried previously. It is an alternative for patients who have symptomatic diabetic peripheral neuropathy. And a systemic review, it failed to identify improvements in predefined endpoints after decompressive surgery in diabetic neuropathy. Is there hope for regeneration? Yes, a lot of research is going on so that we can develop regenerative therapies for diabetic neuropathy and reverse the pathogenesis. So mesenchymal stromal cells, they reduce the levels of inflammatory factors and increase the anti-inflammatory cytokines. What about the gene therapy and exosome-based therapies? They are still in clinical trials, but they hold revolutionary potential for restoring the neural function at the cellular level. A systematic review and meta-analysis found that exosome therapy, it provides a novel therapeutic strategy for the benefit of neurovascular remodeling and functional recovery of diabetic peripheral neuropathy, especially when used in conjunction with exosome modification and novel dressings. So I would like to summarize the current research which is happening. The strongest emerging evidence is for microgabalin, then HSK 16149 and VM202, then actovegin, riboxystorin and NRD-E1 and ARA290. SGLT2 inhibitors, benfotiamine, they are supportive therapies. These therapies have negative or limited effects, that is ABT639, eliapixant and ricoliostat. The experimental and regenerative therapies are in the pipeline. They might show some promise in the future, like stem cells, gene therapy, and microbiome therapy. The future direction of neuropathy treatment will likely shift from symptom control to actual nerve regeneration. Thank you.
Thank you very much, sir. A very wonderful discussion of the management challenges in diabetic neuropathy. Moving on, as we do not have our second speaker for the second session, so we are moving on to our last topic, that is retinopathy treatment. And I would like to invite Dr. Vidhata Kumar, sir, to come on the stage.
Thank you RSSDI. So I'm the only ophthalmologist probably in the whole conference. So sorry for being late, the last session and the last speaker. So I will be talking on the diabetic retinopathy treatment. I've been told to talk about the anti-VEGF lasers, but I will be briefing slight about the different aspects of the diabetic retinopathy and what struggles we face when we get the patient with diabetic retinopathy, and what we have, how we deal with the patients. So how you all can help us. So we all know diabetic retinopathy is a leading cause of blindness, and the first thing that a diabetic patient we see is the retina, and we can see that the retina is the only place we can see the changes that is going on inside the body. So how it damages the body, the chronic hyperglycemia damages the retinal blood vessels, leading to leakage, ischemia, and abnormal neovascularization. So the problem is the chronic hyperglycemia, which leads to the loss of these pericytes which are present in the blood vessels. So when these pericytes are lost, there is a capillary wall weakening, and from there, the weak points, there is a leakage of plasma outside the capillary wall, and there is formation of retinal edema, microaneurysm, heart defects, etc., etc. So these are the brief grading of the diabetic retinopathy, and we all know, we have read in MBBS, mild NPDR, moderate, severe, and the most severe form is the PDR, which we don't want to see at all. So mild NPDR just have the microaneurysm, and this is how a normal fundus looks like. This is the disc and the retinal blood vessels. You can see, you won't see any hemorrhage and any without retinopathy. And when the patient comes with retinopathy, we have to grade whether it's a mild, moderate. So based on the changes like microaneurysm in mild, heart exudates, cortical spots, blood hemorrhage in the moderate, severe will include the moderate plus the ghost vessels and the AIRMA. And if they have the new vascularization around the disc or anywhere in the new vessels, we term it as the PDR. So this is how a PDR, the severe form, looks like when they come very off late. And so what leads to vision loss in these kind of patients, the diabetic retinopathy? Just a diabetic retinopathy won't lead to vision loss. They need to have three things. Either they will have a macular edema. You can see in the picture here, there is a exudation. I don't have a cursor. So there is the macular edema. You can see the OCT picture, and the next is the macular ischemia. The macula is not confused in these patients, and the third cause of the vision loss in these diabetic patients is the vitreous hemorrhage. So whenever I meet an diabetologist, I say, sir, please do refer patients to us for eye examination. They say, we do refer, but when they complain of the vision loss. But this should not be happening. See, this is the patient with moderate diabetic retinopathy, moderate NPDR, and the macula is fine, but the exudation is on the side vision. Both have the exudation, hemorrhage, but the vision is 6/6. Patient did not have any complaint, but fortunately he was referred to us by an eminent diabetologist. So we did the examination and did the whatever was required for him. And after that, the patient became very conscious that so much changes are going on inside me, and his diabetic retinopathy grading improved drastically after we examined the patients. So what ADA recommends is, when you have a type 1 diabetes patients, they should be referred to us within 5 years, and if you have a type 2 diabetes, they should be referred at the time of diagnosis. This is the ADA recommendation. We did a study in our hospital when I was doing my fellowship at Sadguru Nechikitsala, Chitrakoot, Madhya Pradesh. So there are a lot of late presentation patients where we used to see. So we did a study in these patients, and so what was the main reason why they come late? Why don't they present early so that we can do good for them? So what we found that only 30% patients were aware that they need to be referred, they need to say check or get their eye checked. Only 30% were told that they need an eye examination, and rest 70% were totally blind, that they didn't know anything. So how we manage the patient? When we get a diabetic retinopathy patient, we grade them, we do fundus photography, we show them, we counsel them, you have these kind of changes. Then we get the OCT done. FFA is required if we doubt that there is a severe or there is a proliferative diabetic retinopathy. And we do check the metabolic status of the patient, even if the patient is under treatment by any diabetologist. Then come to the management. The very important role is these OCT. They have drastically changed the management style of these diabetic retinopathy. When we have this is the right side is the normal OCT. You can see the fovea where we get the 6/6 vision, and the right one. sorry, the left one is the normal one, and right one is the diabetic retinopathy, the macular edema. And when we suspect a severe NPDR or a PDR, we need to check for the neovascularization, and we do a fluorescein angiography. Then we get these leaks, then we decide the further treatment. So when we have a diabetic macular edema patient, there comes the role of the anti-VEGF. So if the vision is good, very good, then we tend to observe and just keep the patient under metabolic control. And if the vision is below 6/9 or 6/12, whatever, we do subject them to this anti-VEGF therapy. Now there are a lot of anti-VEGF therapy we have. The cheapest one is the Avastin, bevacizumab, we all know, the used for colorectal cancer. This is the cheapest one, around 5,000 to 6,000 the one dose cost. The next is the innovator Accentrix. This is around 15-year-old, and the biosimilars that have come, the cheaper ones, the made in India products, the ranibizumab, the Rajumab, Intas is making it. They have made it very cheap and made it very affordable for the poor patients. Then now the expensive ones is the Eylea, aflibercept. We tend to avoid these costly injection because these patients require a very frequent number of injections. The other group of drug is the Ojodex. It's a dexamethasone implant. There is an implant, it goes inside, stayed inside the eye and keeps on releasing the drug for 3 to 4 months. So once you inject, you are free for the treatment for next 3 to 4 months. The newer molecules have come up, the Vabysmo, these are very costly, around 1 lakh per vial, and the Paganax is around 40,000. The Brolizumab, these are monoclonal antibody. These are very new, we have very less experience, and mostly they are not required in these cases. So that talk. Let's move to the how to manage a neovascularization. Like when we have a patient of neovascularization like PDR, how do we manage? So laser plays a very important, it's a gold standard since last 50 to 60 years when ETDR study was done. We keep doing the laser whenever we have a neovascularization. Unfortunately, the fundus photo I am showing, he's a father of a diabetologist who is settled in US. Uncontrolled diabetes, uncontrolled DM, never bothered to listen to his son and came up with proliferated diabetic retinopathy. Instead of lasering extensively, the disease is progressing and we are unable to control his vision loss. So this is a short video of the laser that we do in these diabetic retinopathy patients. This is a green laser we do. The wavelength is 532 micron, and the indirect ophthalmoscopy, it has a head-on mount of the laser, and the laser goes straight inside the fundus. We do it in 3 sittings. The 1/3 of the retina is lasered in 1 sitting, and rest 2/3 in different sittings. And we keep a gap of 7 days. Now, whenever the severest form of diabetic retinopathy comes to us, like vitreous hemorrhage, we subject them to surgeries if it is not controlled with the laser. And this is a short video that how we do surgery in these patients. So, actually this is the eye and we make a 3-port. It's like a laparoscopy thing. And you go inside the eye, do the vitrectomy here, then enter with the biome. You can see so much of a hemorrhage over the retina, and this is the membrane. This is because of the diabetes, and you have to remove them. This is the toughest retinal surgery you have in this diabetic management. So after the blood is removed, you can see the lasers. Even the patient was lasered, it could not help much with because the metabolic control was not very good. So this is I am removing the ILM layer, the outermost layer in the innermost layer of the retina, and finally the laser is done and the patient gets a good vision. A good vision we can't say, but this is how a fundus looks after surgery. So my take-home message is diabetic retinopathy is preventable cause of blindness. Early diagnosis and treatment can help in sustain long-term good vision. All type 2 diabetic patients to be screened every year, and type 1 diabetic patients to be screened every 5 years, and please do refer them on time. Thank you. This is my team. I work at RSSDI Eye Center, Raja Bazar, Patna. Thank you.
Thank you very much, sir, for your insight into diabetic retinopathy treatment. we all agree a timely referral to diabetic patient to ophthalmologist is very much necessary for their visual health. So we are moving to our question and answer session. I will request our chairpersons to have any questions for our speaker.
Any question from the audience?
My question is to Dr. Abhijit, sir. Sir, you just very well explained the role of peripheral neuropathy and how do we treat that. You explained the role of pregabalin, you explained the role of nortriptyline, duloxetine, everything. But lately I have seen some drugs have come. There are certain chemicals like capsaicin. They are present in form of roll-on or in form of tubes. So what is your take on this? Do they help in treating peripheral neuropathy, or are they just any bogus products, or are they genuine products?
They are genuine products. Capsaicin has been shown to reduce pain and be effective in pain management of diabetic peripheral neuropathy. But we have to remember that the first line agent still remains pregabalin or duloxetine or amitriptyline.
So they can be used as an add-on product, not as the mainstay of treatment. That is what.
But I would like to say that if there is very mild treatment, and we have to remember that capsaicin is only approved for foot neuropathy.
Yeah, exactly.
So if there is very mild symptom, you can give a trial of capsaicin without giving the first line agents.
But first we have to control the sugar, then we have to...
See, once neuropathy has occurred, you won't get any benefit of controlling the sugar.
Okay. Thank you, sir.
Thank you. And the glycemic variability will cause severe pain. If the sugar shoots up or suddenly decreases, the patient will have it.
That's what is,
so time and range is very important in such patients.
Thank you, sir.
Thank you very much, sir. So I would now like to conclude the session, and I'm thankful to all my speakers and chairpersons and for RSSDI for organizing such a wonderful event. Now I would like to invite one chairperson from stage.
I would like to invite Dr. Abhishek, sir, to please felicitate the speakers and chairperson.
Please.
Dr. Vidhata. Dr. Vivek Singh.
The lunch is being served in the delegate and faculty areas, so please join us for that.
Sir. Moderator. Sir.